Okay, is it 10? Yeah, oh, close enough. Okay, we'll open up the public hearing on 12/31 relative to requiring healthcare providers to disclose medical services billed to the patient's insurance carrier. And Representative Dunn is the, oh, okay, standing in.
Morning, Mr. Chairman, members of the committee. For the record, Representative Wayne McDonald. I represent Rockingham County District 16, which is the town of Londonderry. I am sitting in this morning for Representative Ron Dunn, the prime sponsor of HB 1231. Representative Dunn is committed, busy with a work commitment, so he did ask me to introduce the bill for him. As indicated, I'm not the sponsor. I'm not a co-sponsor. I haven't really been involved with the bill at all, so I'm ill-equipped to take any questions, but I'm certainly happy to try if you have something, or I know there's several people behind me who are going to be testifying to include one of our constituents from Londonderry, so
Great, thank you very much.
thank you. That was easy.
Okay. So Janet Hudala? Hudala.
Thank you, Chairman Hunt and the committee. Excuse me, I seem to be losing my voice here. Janet Hudala at 5 Stony Point Drive, Londonderry. And thank you, Honorable State Rep Wayne Dunn, for introducing this bill. You just did an extraordinary job. My 3-minute presentation will address my background and experiences that prompted this bill, why this bill can be easily implemented, and how it will help patients to be proactive on managing their own medical expenses, how it will better ensure here in New Hampshire, insurance companies and governmental agencies are paying for services and products that were actually provided patients. I have lived in New Hampshire for over 25 years. In my younger days, I worked at a hospital. I worked in the emergency room, geriatrics floor, and the neonatal care unit. I supervised a volunteer staff who were in training to become nurses. Consequently, over the years, I became a care provider or the financial medical manager for grandparents and my parents. My mother lived with me for 8 years and died in my home. I was the executor of her estate. I was the manager of the Workers' Compensation Unit for the California Department of Forestry and Fire Protection. I did medical management and approved and negotiated settlements. In an 18-month period from 2023 to 2024, I personally had 6 emergency room visits, 1 surgery, and 2 separate week stays in 2 different hospitals. In 2025, I had major surgery. Obviously, there were several medical appointments happening before and after these events. Additionally, I and some family members have serious reactions to medications that have almost led to death. So we have to assure we don't receive medications or procedures that may exacerbate our medical situation, cause ongoing complications, and incur unnecessary expenses. From the hospital stays, I learned that hospitals have medical care managers who determine the care individual patients receive. I refused having a medical manager as I am competent to determine my own care, and my medical directive states who will handle situations when I'm not able to do so. Excuse me. I refused medications and medical procedures because they were no longer necessary to diagnose or treat my condition or were ineffective. Nevertheless, I was given a medication that had exacerbated my serious symptoms and caused a longer hospital stay. The insurance company and I were not happy at my longer stay. When I requested my hospital medication treatment and billing records, I only received the treatment records I was told I would receive. And I was told I would receive the billing detail from my insurance provider and Medicare. However, the insurance provider and Medicare give only a summary statement. Insurance 30 days or more after billing, Medicare only quarterly. Both only give the medical provider's name, doctor's name, dates of care, and the condition of treatment, the condition or treatment title. Sometimes billing codes are included, but without explanation. My interest in receiving the billing information from the hospital was to ensure I had been billed for services that I actually received. Most importantly, I did not want to be so sick again and in the hospital for so long ever again. I have experienced similar billing and care issues at medical care by medical care providers. One billing issue that involved my eye care for my mother took 21 letters and a year and a half to correct, so my mother could receive further care. The provider billed 3 times for her visit, amending and increasing services and cost each time. I worked with her insurance company to correct the billing. I was astounded when Medicare Fraud Unit told me they didn't care that the billing was not accurate. Thankfully, the insurance company cared. Additionally, the billing delays, and lack of detail caused a lengthy time frame to settle the fiscal issues of my mother's estate and caused me intensified grieving. For the last few years, I have noticed that hospitals and doctors' offices are using computers to immediately and in front of the patients document and submit for billing purposes patient treatment information. Consequently, technology is such that it would only take a few keystrokes to provide patients with billing information that is sent to insurance carriers and Medicare, the same information, when it involves third-party billers, even when it involves third-party billers. In the past few years, I've received 3 third-party notices that my personal medical data has been hacked, and they and my insurance provider wanted me to check my medical billings to be sure I wasn't charged for services I didn't receive. I could not do so because I only received generalities. Why not give patients the billing information they need to responsibly manage and their medical care and cost? If billing accurately reflects services provided, there should be no reason not to provide it to patients. Some of my friends who are nurses and care providers, especially those who have been care providers and executors of estates, agree that such a law is needed. I'm hoping you agree as well, and that the insurance and hospital lobbyists will see the benefit of this law to their client and themselves. And lastly, I would be happy to answer any questions that you might have, and will answer them to the best of my ability. I do want to comment that the bill, when it was written up, I didn't give it a specific time length or recommend it, and I think the time length in it is too lengthy. I would recommend an amendment, given that your insurance provider only gives you a summary. I want the detail of the billing, and that Medicare bills quarterly. So, thank you.
Well, this is a first. Someone comes in praising insurance companies.
I work closely with mine, and I value them.
Okay. So, did you ever ask the hospital for a detail?
Yes, and I was told I would need an attorney.
The hospital told you need to have an
Attorney to get those records because I was going to be getting that information from my insurance carrier and from Medicare.
Right, but insurance carriers are going to tell you that which it was being billed for. And,
Yes.
And like you say, it's general.
Yes.
It's not down to individual medication. It's all the little details that you might have been handled. So I don't understand why could they rationalize that you needed an attorney to request it?
I don't know. I asked him like
Me-
3
what-
times. I went back because when I asked him initially for the medical records of what they had done,
Right.
because part of the story is they almost killed me, but that's another story. And I wanted to have the billing records. I asked for it at the same time, and I picked it up. I was confident I had it. Went home, didn't have it. So I wanted to show what they had billed the insurance company. What I don't get why that's a big problem, especially today, because the nurses are right at your bedside, and the doctor's office are using the computer, and that
Right.
information goes in for billing.
Okay. Any other questions from the committee? Any other questions? Are you willing to part with your? I assume you have that on your computer. That the clerk would greatly appreciate having your
Well-
testimony.
I will, but I got to ask Wayne because I wrote his phone number down here. Is he okay with? Oh, he's gone. Well, I guess he's okay, right? You all have his phone number, and forgive my typos. Okay.
Yeah. Yeah.
Okay.
Yes,
Absolutely.
We know Wayne's phone number. Yes.
Pardon?
We know Wayne's phone number.
Okay.
Okay.
Both of them.
Good. Thank you very much.
Thank you.
So from the opposing view, we have Christian Ramsey from the New Hampshire Hospital Association. Thank you very much.
Morning, Mr. Chairman and members of the committee. My name is Christian Ramsey. I'm the Director of Financial Policy and Reimbursement with the New Hampshire Hospital Association, representing all 26 of the state's community hospitals as well as all specialty hospitals. Thank you for the opportunity to provide testimony. The Hospital Association is opposed to HB 1231. It's important to note that most of the information this bill seeks to require is already provided to patients today in a document called an Explanation of Benefits, which is issued by insurance carriers. These documents help patients understand how much their health plan covers and what they'll need to pay when they get a bill from their provider. An EOB can include, but is not limited to, a description of the services the patient received, the dates of those services, the amount charged to the insurer by the provider, any allowed amounts, which are the amount the provider will ultimately be paid, and then the amount paid by the insurer and what the patient's balance is. Additionally, under RSA 151-12-A, hospitals are already required to provide patients with itemized bills upon request. These itemized bills include CPT codes and the amounts billed for each service. What hospitals don't have and cannot provide are insurance-specific allowed amounts or payment determinations by code. That information resides with the payer, not the hospital, and is communicated through the insurer's remittance advice and EOBs. This legislation would create significant operational challenges that cannot be resolved simply through compliance efforts. Hospitals don't receive payment information from insurers within the 15-day time frame contemplated by this bill. Commercial insurers can take up to 45 days to adjudicate a claim, and Medicare has a payment floor of 21 days once a clean claim is received. Requiring hospitals to provide payment details before that information exists is not realistic. To add to the challenges outlined so far, not every patient a hospital treats is enrolled in or actively uses a patient portal. As a result, this bill would likely require hospitals to print and mail paper statements for a large volume of claims, which would substantially increase administrative burden and costs with no improvement in clarity or care for patients. Compliance with this bill would also require reprogramming of hospitals' electronic medical record and billing systems. These systems are not currently designed to generate insurer-specific payment breakdowns. In closing, the Hospital Association supports transparency and patient access to information. However, HB 1231 seeks to impose distribution of information that patients largely already have access to. If the legislature is interested in mandating CPT code information for every patient, that change should be made to the EOBs issued by insurers. For these reasons, we respectfully urge the committee to find this bill inexpedient to legislate. Thank you for your time. I'm happy to answer any questions you may have.
Okay, what was that RSA number that?
RSA 151-12-A.
Okay, all right. So in RSA 151-12-A, does it say that upon request?
Yes.
Okay.
Yep.
So she did ask for it, and upon request, they said no. My guess is that she used the wrong terminology. She shouldn't have said, I want to know what you're billing my insurance company. She should say is, I just want what you gave me, what you service. Forget about the insurance company at that point.
Yeah.
That if I read 155-12A, will I read it is that anybody is allowed to get a printout of exactly what service was provided.
Yeah, it's a specific breakdown that includes the CPT codes that were billed to the insurance carrier. I can't speak to anybody's individual cases, but
No, I don't have to. You
yeah.
go on about how we're going to do this for everybody, but not everybody wants this. Okay, so the question was, we've already done this statute, we've
Right.
already put it on the books,
Right.
and that the only problem is that she didn't ask. She somehow accidentally mentioned insurance company in our insurance department, but all she wanted was just her billing. So you would agree with me that they should mail her a copy of if she just asked for just that.
yeah, it's standard practice for a hospital, and they're required under state law to provide that statement for what CPT codes are billed to a patient's insurance carrier.
Great, thank you.
Yes, sir.
Any other questions from the committee? Representative Welch.
Thank you, Mr. Chairman. Thank you for taking my question. On your testimony here, down here it says, What hospitals do not have and cannot provide are insurance-specific allowed amounts or payment determinations by code. I don't see where it asks for that in this bill.
I don't have a copy of the bill in front of me, but I would have to take a look at what the bill language is.
It says billing code or codes used.
Oh, okay, 3.
Yeah.
All right.
Okay. Any other questions from committee members? Seeing none, thank you very much for your testimony.
Thank you very much.
Is anybody else interested in testifying on 1231? Please go ahead and call up your hospital, refer to this RSA number. I hope you wrote it down. And tell them that you don't need an attorney, that this is in the law, and you would like to have a copy of your printout. And what we'll do is we'll keep this bill around, so that come September, if you still haven't gotten that statement, come and tell us.
Okay, but I did not.
You have to come up to the microphone here. It was already on.
Sorry. I did not, I asked for the billing information. I asked it for in person 3 times.
Right.
Okay, so, and like I said, let me ask this question. Does the RSA have me go to my insurance company to get the detail?
No.
Or the hospital is
Hospital.
absolutely supposed to provide it?
Correct.
Or any other?
On your request.
And, right, and upon anybody else. You actually have to fill out a form of what you're requesting.
That
So-
might be true.
Yes, so there was no miscommunication of what I wanted. I'm not known for miscommunicating, and some of you on this know that about me. So I do,
So
is
give it a
there any
try,
administrative
we'll meet
reinforcement?
We'll
Is
meet
it-
again in September, and
Okay.
hopefully you can come and tell us that how wonderful that printout and how many pages it is.
Thank you. Oh,
Yeah. Yes.
Thank you. Thanks for taking my question. I may have missed it. Did you meet with anybody at the hospital at a senior level, like the CEO?
no, I did not. I just dealt with the billing agent.
I would strongly
records.
suggest doing that next time. And if that doesn't work, you go to the PR person and say you're going to write a letter to the editor. That usually works pretty well. And if that doesn't work, you say your uncle is on the state Supreme Court. That's it.
No, I'm not into lying. But thank you.
Okay.
Thank you very much.
Yes.
Oh, there was something else I wanted to add about it, but I've lost it. That's an
Right. Okay.
important point. Thank you.
Ben, did you want to?
Going to reference the RSA and read it, but
Okay. I guess my only question is, does the RSA have a timeline in there?
within 30 days of such service.
Okay, so they have to request it within 30 days? Or that they have to respond within 30 days? Yeah, why don't you read the statute?
Thank you. For the
Okay.
record, Ben Bradley. I work for the Hospital Association as well. Just going to provide some reference to the RSA. Any provider of medical services, including physicians, facilities licensed under this chapter, and nursing homes, as defined in RSA 151A:1(4). So in addition to all those, who is to receive payment from a third party shall provide the person receiving such services and the third party with an itemized statement within 30 days of such service. The statement shall contain a list of services rendered, the dates on which such services were rendered, and the cost of those services, provided, however, that a non-itemized bill may be rendered if it includes a large, easily readable print. The following: an itemized bill will be gladly submitted for free of charge on request.
Okay, so I see a fault in the law that has the magic word "or." So we're going to have to amend this law. So
State, I'm not sure where I'm seeing or. Mr.
you
Chair.
said that they are to give the patient the printout or
However, that a non-itemized bill may be rendered if it includes in large, easily readable print the following: an itemized bill will be gladly submitted free of charge on request. So that's where
But
we're
again,
talking
that's
about.
combining things on the billing, right? That's a merging. Right.
It's upon request is what it's saying.
Still, but in other words, could she request it now,
Yes, absolutely.
months later?
Yeah.
Okay. All right. Maybe I wasn't listening clear enough.
The RSA is, if I may, 151:12A,
That, okay,
and it's titled Itemized Bills
itemized bills. Okay,
from last amended in 1983.
okay. So you will make sure you help her out?
I'll,
make
I'll
sure-
gladly take her information and try to
and-
connect her with the
and
right
Make
people.
sure that gets done. Great.
Certainly.
Thank you very much. Okay, we'll close the hearing on 12:31, and we'll open up our next hearing at 13:47, right? Is it 10:30? No, it's not 10:30 yet.
What was his last
Real, okay.
What was his last name? He's also with them.
Yeah. Okay. 13:47. Okay. Do I have a sponsor? Tell us.
Representative Tellez,
Or Nagel? Okay.
Representative Nagel. Anybody? You want me to introduce it?
It's technically not 10:30 yet, so.
Yes, right, 10:30. So we got 7 minutes. Ah. So, did you get any cross-country skiing?
I did. We did several. We did beautiful. It was because we have a groom. We have so much snow out there. We got one of those grooming machine. My employees got the and so it makes a nice corduroy.
Oh, you kidding?
So the whole trail system is corduroyed and we just had a grand old time. And
You
then
must have had a
then they also had plowed off the lake, so the kids got to go ice skating.
Oh, my God.
So they had a wonderful weekend.
That's super.
Yeah, that worked out really great.
That's awesome.
Are they local to you or
What's
far
that?
away? Your kids?
Well, these actually the one live in Rhode Island.
Ah,
So yeah, actually nobody lives in Ranch now.
okay.
Yeah. We don't go about Yeah, no, we seem to watch the ice, but I would say my biggest drive to keep up with it is taking out is whether they go out there with like spots. Right? So in my company, we send out the tractor, John Deere tractor, to take the snow. So just strap. So they're the ones who will go down. Well, no, But I would say this, that, you use a farm fund, and the farm fund definitely has a spring. So there is certain areas if you don't, you know where the spring is, so you don't use it. But it was easier just for him to drive down to the road. You know, go down. Okay, what do you like? You see, I just kind of around there. That's what I would say. This is one of the first winners. Much. You mind just filling out a card? That'd be great. Thanks.
Oh, yeah.
Right. Representative Tellez? No, no, this is, Sabrina, okay. So do we have a sponsor?
1638.
Okay.
Anybody here for 1347?
Anybody in support of 1347?
Anybody against?
Oh, God. You're in support, oh, you're down, right, that's. Okay. All right, this is unfortunate, okay. No, he would be the opposite,
Want me to introduce it?
sure.
I'm doing it.
I've always thought it's a waste of time, but that's fine, we'll play by the rules. Okay, so first, while you're down there, John, while you're down there, change the card for us. The, because
1347.
we're missing the sign right there.
Oh, yeah, I will do that too.
That made it all worthwhile.
That's what being vice chair is all about.
Okay, well,
Jack of all trades.
yeah, that's, we're missing our youngsters. Well, no, but
Ooh,
1,
nice
2,
pen.
3, 4, 5, 6, 7, 8, 9, 10. So in the old days, we could have exec right there. We could have said, oh, let's go in an exec session. But okay.
It's 10:30. House Bill 1347, Representative John Patusik, Vice Chair of Commerce, to introduce this bill. This bill prohibits healthcare facilities from refusing referrals from independent and outside primary care providers so long as the healthcare facility and specialists accept the insurance of the patient, and establishes penalties for failure to comply. Please don't ask me any questions.
Perfect. Thank you
Thank
very
you.
much. Okay. Okay. So, Alexandra Surinsky from the New Hampshire Attorney General's office. Good morning. Yeah, you have to put,
Oh.
red is good.
Red is good.
red
All
is
right, there we
good.
go. Good morning. My name is Alexandra Sosnowski. I am a Senior Assistant Attorney General with the New Hampshire Attorney General's Office in the Consumer Protection and Antitrust Bureau. I'm here today in support of HB 1374. This 74? 47. I'm sorry. This will ensure that consumers can obtain necessary referrals to healthcare facilities in our state if they have an independent primary care physician that they prefer to see. I do have a couple of suggestions for this bill if it were to move forward. The first would be to align with the Consumer Protection Act enforcement provisions and standards. This would help with the civil penalty that currently is listed as a $100,000 civil penalty. The Consumer Protection Act has a maximum of $10,000 per violation. And by incorporating with the Consumer Protection Act, it will align our enforcement capabilities, subpoena power, that sort of thing, so we can act pursuant to that law. Second, we have a concern regarding the revocation of a healthcare facility's nonprofit status that's included in this bill. So once a nonprofit registers with the charitable trust unit properly, they're in good standing. And so this bill does not have a mechanism of due process to revoke that status. So we would be concerned with the lack of due process in that. We also think it would be sufficient for enforcement if this was under the Consumer Protection Act. And for our office, if necessary, we could make a referral to the charitable trust unit. If it did encompass a nonprofit that we were worried about, we could make that referral to them. That's all I have. Happy to take any questions.
Okay, so you're opposed to the penalty section. Yeah.
I'm not opposed to the penalty. I just think
Well,
you
you're
could
just-
align it with the Consumer Protection
no,
Act for
it-
consistency.
It doesn't make any sense. You're right. Okay, 100,000 elusive license. It's pretty draconian. So let's just get to Roman numeral 1. And which it basically says that a healthcare facility has to accept any patient that is being referred to it, regardless which physician is referring.
Correct.
So don't you kind of think that kind of mucking around in contract law in terms of how a healthcare facility has contracts with the physicians and third parties?
So I believe it's a referral, not a contract to serve the consumer. So a referral is from your primary care to get specialty services, for example, at a particular facility. So as long as it's written here that the insurance coverage is included at that healthcare facility, it's just to prohibit the discrimination based on your primary care physician, is my understanding of the bill.
Okay, so you don't see this as an awkward situation at all?
I do not.
Okay, fair enough. Thank you very much. Or anybody else have any other questions? Yes, Reverend Zerchak.
Thank you, Mr. Chairman. Is this a problem or a bill in search of a problem? I mean, I don't see why, if the practitioner knows that he's going to get paid, why they would refuse. Is this happening all the time?
Thank you for the question. I am not aware of any complaints to our office about this type of conduct. However, pursuant to our investigations and enforcement of hospital merger transactions in the state, we do include a similar provision in many of our consent decrees that would prohibit this type of discrimination based on your primary care provider, in order to ensure that people have access and to maintain independent primary care in the state.
Thank you.
Great, thank you very much.
Thank you.
Okay, so we're going to go back and forth here so we can do a good conversation. So why don't we start with Ben Bradley for the New Hampshire Hospitals? Okay, okay. Oh, the sponsor. Okay, sorry. I will invite the sponsor to speak.
Thank you, Chairman Hunt, and esteemed members of this Commerce Committee. I'm Representative Trinidad Tejas, the prime sponsor of this bill. I'm a family physician and a health services researcher by training, and I represent Hillsborough District 40, which is 5 wards in Manchester. I just handed out an amendment that I worked with OLS to just add a little clarity, a little bit changing of the wording. So it's basically about no entity shall prohibit referrals from independent and outside primary care providers so long as the entity accepts the insurance of the patient. In plain terms, if a specialist and a primary care physician are both in network with the patient's insurance, and a health system should not deny the patient access to the specialist merely because their PCP is not employed by that system. This bill addresses a growing concern. Large health systems, which are comprised of medical groups and hospitals, are increasingly restricting access to specialty care unless patients abandon their longstanding primary care physician and establish with a system-employed PCP. To illustrate this issue, I'm sure many of us have primary care providers, such as a family physician, an internist, a nurse practitioner, or a PA, who we see regularly. And they may be employed at a health system, or they may be at an independent practice. Then, as often happens, we may at some point need to see a specialist. But the only specialist in our insurance network is employed in a different health system. Our PCP makes the referral to the specialist that is within our insurance coverage network, and when we call to schedule the appointment, we're told there's no availability unless we switch to one of the primary care providers employed by that health system, the one where we're seeking to see the specialist. As a family physician and a health services researcher, I know that this interrupts continuity of care, which decades of research shows improves outcomes. In fact, we know that one of the strongest predictors of people's health is whether they have an established relationship with the primary care provider. And this is just wrong. This goes against patient autonomy and choice, essentially discriminating against a patient based on who they have as their chosen PCP. Finally, let's remember 2 important points. All hospitals or health systems have in their missions, especially entities with nonprofit status, an obligation to care for the people in their geographic catchment area. And this is not an insurance coverage issue. We know that if specialists are in an insurance network, they should be able to see the patients who have that insurance coverage. In fact, the American Medical Association House of Delegates identified this practice as concerning and unanimously supported barring the practice by adopting a policy directive stating that health systems should not require patients to switch PCPs in order to access specialty care, and that these practices, resulting from healthcare system pressures or economic incentives, are ethically unacceptable and harmful to patient welfare. Continuity with the primary care physician reduces emergency visits, hospitalizations, and overall costs. Disrupting established primary care relationships worsens outcomes and increases readmissions. It prevents primary care practices, specifically independent practices, from collaborating with their specialist peers for optimal care, And in rural areas, it essentially limits referral access, effectively eliminating specialty care for many patients. However, since drafting this bill, I've had some conversations that have uncovered the challenges with addressing this issue, including with folks from the Department of Insurance. There is no denying that patients and providers are currently encountering a barrier. We clearly have a problem. However, it's unclear how to address it, as it falls outside the protections currently in existence. This is about access to scarce specialists, and it's unclear what laws apply to employed physicians as part of large medical groups. What entity has oversight? It's not the insurance department. Employed provider groups may be legally set up as a separate entity, but in reality, they roll up to the hospital or health system. So the problem is there's no regulator for how health systems operate in the market. If this bill were to pass as originally written, who would enforce it? Who would have appropriate authority, and what authority would they need? Who would patients and providers even complain to? We also recognize that we can't impose absolutes, as my hospital association colleague is going to point out. We can't force providers to see all patients because sometimes there are legitimate reasons for declining a patient, such as safety concerns. However, today I'm speaking about an issue that is fundamentally about unregulated healthcare financing and market forces. As the AMA included in their ethically grounded referral practices policy directive, systems should not use value-based payment structures to coerce patient capture. So I'm asking you now to create a study committee with membership by House, Senate, Insurance Department, AG's office, and industry representatives together. A study committee can work on determining how widespread this problem is and what are actual options for addressing this very real problem. In conclusion, HB 1347 is a straightforward, ethical, patient-centered bill that protects continuity of care and preserves patient choice. It ensures that New Hampshire residents can continue seeing the primary care clinician they trust without losing access to necessary specialty care. It aligns state law with national medical ethics and reinforces the importance of a stable, continuous primary care relationship. Creating a study committee and bringing the various stakeholders together will allow us to assure fair access to specialty care without imposing new financial obligations on specialists or insurers.
Okay, well, I just, so you're saying you're not ready to go forward with this amendment? You
So
would rather us
that,
do a
that,
study
that amendment
committee?
clarifies the bill, but actually what would be even better is if
Having a study
that's the
committee.
better language, but probably in talking to other people and realizing the AG's office doesn't really have oversight of independent medical practices. The insurance department does not have oversight of independent medical practices. There's not clear who has oversight of independent medical practices. And so it's a little more complicated. So it is a real issue. Everyone will admit that. The magnitude is not completely clear, but having a study committee would allow some opportunity to get a sense of that, but more realistically, just figure out how do we address this issue.
Yeah, so historically, this committee, we take care of it ourselves.
Oh, okay. As an
So,
interim.
yeah, as an
Okay,
interim study.
sure.
Okay, any questions from the committee members? Seeing none, thank you very much for
Okay,
your
thank you.
testimony. Okay,
And I'll provide my written testimony in a
that would
little
be
bit.
great. Okay, so now, given that we're going to probably interim study this bill, Ben Bradley from the New Hampshire Hospital Association, who will explain why the Hospital Association is in opposition to the bill.
Thanks, Mr. Chairman. Again, for the record, my name is Ben Bradley. I work for the New Hampshire Hospital Association, and we represent all hospitals in the state of New Hampshire. We are opposed to HB 1347, which prohibits providers from refusing referrals, imposes a $100,000 civil fine per violation, and removes an organization's nonprofit status if the facility is nonprofit, turning it into a for-profit. It is our position that providers with capacity to take on new patients will do so and work with patient referrals from anywhere to accommodate access to their services as best they can. However, we do not support referral mandates for many reasons. While we acknowledge access for specialty services is challenging, as pointed out by the sponsor, we have several general concerns about the policies outlined in the bill, in addition to several technical concerns with the language. First, inappropriate circumstances for a referral. There are certain scenarios when a provider could ethically refuse a referral that are not acknowledged in this bill. Among several examples would be when a provider doesn't believe that their expertise would address the patient's needs, or when a provider feels, as noted, unsafe treating the patient. Second, referral mandates create longer delays. Mandating providers accept referrals from anywhere would add to existing delays for patients. As I noted, we acknowledge that waiting times for existing patients can be long. By mandating providers accept all patient referrals, we would anticipate even longer wait times for patients in the provider service area or healthcare system. Third, this bill's application to a licensed healthcare facility versus a provider group or the provider that's making the determination. The language in SB 1347 targets licensed healthcare facilities, enacts that steep civil penalty, and removes the facility's nonprofit status. However, the licensed facility is not making referral decisions. The provider or provider group is responsible for referral decisions. This is a technicality that I know the sponsor has acknowledged and may render the bill defective as it is. Given these concerns, the Hospital Association can't support the bill, but while we appreciate the sponsor's attention and interest in improving access to care, our members oppose this referral mandate because they're concerned it would increase wait times, overburden providers trying to manage their existing patient volumes. I'd be happy to take questions.
I hope you're willing to share that testimony.
Yeah, so I
clerk.
forgot all about that.
Okay. Any questions from the committee members? All right, seeing none. Chair will call on Kathy Stratton from New Hampshire Medical Society. Good morning.
Good morning. Thank you for taking my testimony. For the record, my name is Kathy Stratton. I'm the CEO of the New Hampshire Medical Society, and I'm here today to speak in support of House Bill 1347 as amended and proposed. My testimony is going to be a little rough because I'm piecing things together today that I had prepared in advance. But basically, we see this as a straightforward patient-centered proposal to ensure that individuals have access to scarce specialty care and services when medically necessary, regardless of who provides primary care. When patients choose a primary care provider, their decisions are shaped by trust, convenience, philosophy of care, and personal preferences. We want to respect that. Some select a physician who's employed by a large health system. Others choose independent physician or concierge private practice. These are all valid choices that we want to respect. And this bill ensures that regardless of practice size or business structure, patients retain access to specialty care services when additional medical care is necessary. And we want to point out that the question was asked of whether this was a bill in search of a problem, and we have heard from our small independent primary care physicians that this is a problem and a concern to their patients. So we're here to advocate for equal access to specialty care. In theory, all patients should have a pathway to specialty care, and we want to advocate for the removal of barriers and access and choice for patients. As was pointed out earlier, continuity of care improves outcomes and reduces unnecessary hospitalizations and lowers overall healthcare costs. HB 1347 reinforces those relationships and protects patient choice. Importantly, this bill does not require specialists to accept out-of-network patients. It does not interfere with clinical judgment, and it doesn't mandate referrals or override medical decision-making. It simply ensures continuity of care and equitable access to medically necessary specialty services. So we encourage ought to pass on the bill as amended, and if it's decided that this should be interim studied, then we support that as well.
Great, thank you very much. Having no questions? Okay, I have one card left. Kate Horgan.
Thank you.
Thank you, Mr. Chair and members of the committee. My name is Kate Horgan. I'm here on behalf of the New Hampshire Association of Counties. I don't spend a lot of time in this committee, but very happy to be with you today. I represent all of your appointed and elected government officials. In this case, the 11 county nursing homes. 3 of the county nursing homes have what are called atypical beds, which are a higher level of care that are received. And those 3 nursing homes are Cheshire, Merrimack, and Stratford County. If this bill were to go into effect, the situation we could see happening is, I'm going to pick on Cheshire because Representative Hunt is in front of me, and Catherine told me I could. So if someone were referred to Cheshire County and they needed an atypical bed, but there were no atypical beds available, but there was a regular bed available, that Cheshire County would then have to accept that person into that bed because there was an available bed. We also don't know how this is going to interact with wait lists. County nursing homes quite frequently have wait lists that are over 100 people long. I believe Catherine told me on Friday, Cheshire was at 108, I think.
Yeah.
So we would be happy to participate in an interim study to make sure that decisions are being made not just based on insurance exception, but clinical appropriateness and bed availability. And I'm happy to take any questions.
Let alone exempting nursing homes.
That too.
Okay. Did you have a question?
Thanks for taking my question. Did you say you also oversee Mountain View in Carroll County?
We oversee all 11 county nursing
Okay,
homes.
perfect. Thank you.
Yep.
Always a pleasure.
Thank you.
Okay, I have no more cards. So we'll close the public hearing on 1347. And we're a little behind, so we can jump right in. Good morning.
Good morning, Mr. Chairman. Thank you, and thank you to the members of the committee. For the record, my name is Representative Julie Miles. I represent Hillsborough County District 12, the town of Merrimack. I am a nurse leader, educator, hospital house supervisor, and I worked in the field of clinical data, research, and health insurance. My central mission, both professionally and personally, and as a legislator, is to improve access to patient care and patient outcomes. I myself am very fortunate to be a member of a premier boutique medical practice called Delphi, but many patients are not that fortunate. House Bill 1813 is about protecting patients from disruptions in care that occur when insurance carriers make unilateral mid-year changes to contracts, provider contracts. These changes often happen quietly outside of the main contract through provider manual updates, reimbursement policy updates, or coverage rules that govern how care is delivered and paid for. In practice, this can mean that a service a patient has been receiving all year may suddenly be deemed not covered or subject to new restrictions. For example, hospitals have experienced mid-year changes to prior auth rules for imaging or infusion services, leaving patients with delayed or forced to reschedule medically necessary care. Behavioral health providers have seen sudden changes to visit limits or documentation standards, causing claims to be denied after services were already delivered. These are not hypothetical situations. These are occurring in real time every day. While some updates are necessary, such as national coding changes or regulatory requirements, many other changes are driven by internal carrier cost-saving strategies. Providers are given 60 days notice, but large healthcare systems must reprogram billing software, retrain clinical and administrative staff, update patient-facing guidelines, and if they can't adapt quickly enough, claims are denied and patients are caught in the middle. Hospitals and providers attempt to negotiate protections against these disruptions, but carriers can typically refuse. Walking away from a contract is rarely realistic because it would remove access to care for thousands of patients who rely on these networks. As a result, providers are forced to accept shifting rules while still being expected to deliver seamless care. This bill does not change the underlying contract. It simply addresses the supplemental materials on top of the contract. HB 1813 does not interfere with contract negotiations or set reimbursement rates. Instead, it establishes simple, reasonable guardrails, and it limits unilateral contract changes to a predictable quarterly schedule. It requires carriers to clearly mark changes so providers can easily understand what is being modified. And when a change is expected to generate more than $500,000 in savings, it requires transparency through a good faith estimate shared with providers and the Department of Insurance. These measures promote stability, improve communication, and help ensure continuity of care. They protect patients from unexpected coverage disruptions and help providers focus on delivering care rather than on constantly chasing rule changes. By establishing this predictability and transparency, House Bill 1813 ultimately helps control costs, preserves access to trusted providers, and improves patient outcomes. I respectfully ask for your support of this measured and patient-centered legislation. Thank you.
Okay. Silly me, I thought people did contracts once a year, not multiple times a year. So section 1 and 2 of the bill, saying, okay, we'll do it 4 times a year. We'll have a window in which contracts. But section 3, oh my God. Do you really need this section 3 in the bill? Because starting to do good faith estimates, 500,000, publishing and having a department, but that seems like way over the top, that to me. So in other words, I'm okay with 1 and 2, but do you really need section 3 of this bill?
$500,000 is a lot of money, and it's significant in these types of arrangements. Again, it doesn't affect the underlying contract at all. These are simply documents that are above and beyond the contract that do have material effects on the costs of services and providers.
Right. Well, they all have that, right? I mean, that's the whole point of what's being discussed in the contract. But just when you having the good faith estimates and reimbursement, and saying, okay, reimbursement, when's the 500,000 kicks? It just seems like problematic to me.
There aren't a lot of $500,000 one-line items, so it wouldn't be that much administrative burden whatsoever.
Okay. Representative. Oh, I thought you. Okay. Any other questions from anybody else? See none. Thank you very much. Okay. So we'll start with Michelle Heaton, since the insurance department is being dragged into this bill.
Good morning. My name is Michelle Heaton. I'm Director of Life and Health at the New Hampshire Insurance Department. It is our understanding that this bill would amend 420J8, which is specific to the contracting requirements between a health carrier and provider. As some of you may know, the department does not regulate the contract, but we do ensure that there are certain, mostly consumer protections included in that contract. So certain things that must be addressed and certain rights need to be in those contracts. And one of those things is actually, it does provide already that there must be a 60-day notice provided if there are any amendments to the provider manual or anything that would impact the contract. So that is already included. I think what this bill is really looking to do is to limit the carrier's ability to make any of those changes to only 4 times a year and at a specific schedule. I'll let the carrier speak to the administrative portion of that and what that means, but I think it's my understanding that some of these changes are due to changes in CPT codes, changes in regulations, changes in different things, and so to limit it to only a couple 4 times a year at those specific periods of time it could be difficult for the carriers to implement that and to make sure that things are operating as efficiently as they should be. The provider contracts are extensive and they are negotiated between sophisticated parties. And when I say that, I mean that these are people who possess business acumen, familiarity with the industry, and the ability to evaluate risks and engage with their legal counsel to help them with this process. So generally speaking, for that reason, the department stays out of those, and the legislature has kept us out of that. So we don't necessarily want to get involved in that. I think that the reporting requirement here, I think it's going to be very difficult to anticipate what some of these changes would mean for each provider's billing. So I'll let the carrier speak to that, but I think from an objective standpoint, I think it's going to be difficult to do that type of assessment. And then I'm just not really sure what the department is supposed to do with that. I think we're just posting it on the website, but I don't know what the purpose of that is. I think these are, very complicated contracts, and this is not something that the average consumer would it would benefit them. I think there's a lot more important things the department's doing with our transparency and coverage and our health costs work that really gets down to the cost of these services. And I think that is, from a consumer perspective and probably even to providers, much more helpful. So I think that's why we put in our fiscal note, indeterminable. Some of this stuff is probably going to increase administrative costs for carriers to comply with. It's going to limit their ability to make those adjustments as things change. And administratively, I don't know how we would ever assess whether they're complying with that 500,000. That would be a complicated analysis that I don't know we'd be in the position to do. So I think from an insurance department perspective, we would probably limit it to whatever they report to us posting it on our website, because that would be a difficult thing for us to do much else with. So I'm happy to take any questions if you have any.
Okay, thank you. And now, flash from the past, Nick Bayless. Who is in opposition to the bill. What, you think we are the Senate or something here? Yeah, we'll pass them around. Keep one for the bottom. So nice to see you again.
Same here, really. It's been a while, and
A long time.
and I appreciate you all having me. And I also appreciate all that you do for the citizens of our state. I've been a healthcare provider for 40 years, representing mostly independent providers. I started Delphi Enhanced Primary Care Group, which was just referred to earlier. I employ physicians, nurse practitioners, PAs. I oversee surgical centers. And I'm proud to tell you the landscape in New Hampshire is a lot better off than Maine and Vermont because we have choice. A couple of things to understand in healthcare dynamics. Healthcare is broken, unequivocally. And the reason being it's totally void of free market forces. Hospitals have been in an arms race to employ doctors for decades now. So they don't have to really compete. They basically refer to themselves. When you control your primary care base, it's a self-fulfilling prophecy that you just, regardless of the competition around you, regardless of what prices you charge, you don't have to compete. your employed primary care doctors will refer to the employed specialists, who then refer to the hospital. What you have in front of you are prices, are the price differences in services. You literally can be in the same market 5 minutes away, and your services will be 5 times more than your competing independent facility, and yet you still will thrive. Okay. Access and affordability is key. Okay, affordability is the leading obstacle to access to health care. Leading cause of personal bankruptcy in the state as well as in America is healthcare debt. Think about that. Not only in America do you get sick and injured, we're going to bankrupt you at the same time. That's what's going on. It's awful. We can do so much better. We can do so much better. And the previous bill that was being discussed about independent providers, so important. They are your lowest cost provider. They could be shut out of the market because they can't refer their patients to a hospital system. Think about that. It's a bill that should be highly considered. So
You're talking about the
the
one we
previous
just heard.
bill, yeah.
Yes, the previous bill.
Yeah.
Okay. I wasn't sure where you were going.
Yeah,
with
no,
this. Okay.
I didn't want to confuse you, but it's
You
so
did.
important.
Thanks.
You also see another graph in front of you that basically, we talk about pharma and the ills of pharmacy. Well, the leading cost driver in healthcare are hospitals. Not that they're not bad people. This is the way business is being done. Okay? We can do better. But when there are no free market forces at play in healthcare, this is what you get. You get high costs, unabated, keep going up. This past year, people are getting crushed on premiums. Okay? And we're better off than Maine. The premiums in Maine and Vermont are much higher than ours. The reason being in New Hampshire, over time, we've been able to create reforms that have allowed patients to seek lower cost facilities. This bill that's in front of you that's being considered would deter that. We owe it to our patients, and health plans, I believe, owe it to their subscribers to seek lower cost providers. Same services, oftentimes better quality, better access at a far lower price. And the people who can least afford health care, if they don't have access to lower cost care, we're going to hurt them even more. Also, the state of New Hampshire, who's the largest purchaser of healthcare services, would see higher costs if health plans were not allowed to encourage, to guide patients to lower cost care, because the difference is immense. Just diagnostics, simple labs, MRI, literally $700 for one MRI, down the street, $5,000. Now, if you're in a $12,000 deductible or a $6,000 deductible, wouldn't you want to know that you could save thousands just by simply going 10 minutes out of your way? I get people coming down from the North Country, in Berlin, and I spend a lot of time in Errol and Colebrook. They drive all the way down to Manchester to save $4,000 on an MRI. This is real. This is what's going on. Representative Miles, I think, has the right idea about access and affordability. But we cannot prevent health plans to help their subscribers or employers guiding their patients and employees to lower cost providers, because the savings is in hundreds, if not thousands of dollars. And so this is not a good bill. Simply put, we owe it to the people who can least afford health care to let them know where they can seek lower costs. You want to know. We have all gravitated to high deductibles. People, look at what's going on in healthcare. You're paying more for insurance and you're getting less coverage. So that you, as an individual, you're pretty much self-insured unless it's a catastrophe. Okay? So because people now pretty much self-insured for routine care like diagnostics, we owe it to them. It's a good thing. It's a good thing. More than happy to answer any questions.
Representative Spear has a question.
Thank you. If you could clarify this for me.
Sure.
I can see shopping around a little bit for routine care. But how, having been through a heart situation this past summer, there was no way I could shop around for anything. I was not in any condition to shop for anything. They tell me what to do, they tell me where to stand, and they tell me what I'm supposed to pay, and I'm doing it. How do you expect somebody to be able to shop around in a situation like that?
In an emergency situation, you're not going to shop.
It wasn't an emergency. I mean, I waited 3 weeks to get in.
Wow. Well, then,
I mean,
if
3
it's
months.
elective,
Sorry, 3 months.
care, 3 months, if it's elective care, you should shop. You could be saving yourself, your employer, and there's information as to where the lower cost providers are. Total joint. Cost differences in total joint replacements. Many of us are in that age group. You could save $60,000 to $70,000. That's a lot of money for an employer. State of New Hampshire has a lot of employees, especially those in retirement. Okay. People need to know where they can go and receive and possibly save tens of thousands of dollars. You do that when you want to buy a refrigerator or a stove. Shouldn't you want to do that when you want, even an MRI or a total joint or the cost differences are astronomical. And part of the fault is the government. They have 3 different fee schedules, believe it or not. The federal government puts out 3 different fee schedules as to who gets paid what. It's price fixing, okay, which is actually a communist solution for a free market problem. But the fact of the matter is there are 3 different fee schedules. There's the hospital rate, the hospital outpatient department rate, and there is the independent provider rate. Okay? That difference could be 5x, believe it or not.
Representative Herbert.
I think I'm getting confused about the word free market.
Okay.
It sounds to me like there's a monopolization of going on in the sense that some of these very expensive procedures are being controlled. I don't think the government calls them up and says, no, you have to go to $50,000. So I'm trying to figure out. To me, the free market's all over this place, but there's coercion here, and I'm trying to figure out if that's something, ironically, that the government could do.
Your instincts are spot on. There is monopolization going on in healthcare. Okay? And we do need better consumer protections, if you may. The leading cause of bankruptcy is healthcare. That's awful. That's awful. Then free market is not the total solution. Okay? Some people, as a result of no fault of their own, get catastrophically ill or injured. Okay? They need protections. But for the vast majority of healthcare that we provide in the non-Medicare space, it's elective in nature. You have time. And you should be aware of the price differences because they're immense. When you go to shop, can you imagine shopping, let's say, a Cadillac, and you have a Cadillac dealer that charges $120,000 for the car, and you have the other one that charges $20,000. Those are real number comparisons, by the way. That Cadillac dealer's $120,000 car would go out of business in no time if there were checks and balances. Okay? That doesn't happen in healthcare. How can someone offering a service $70,000 more than another one thrive? Never mind just get by, but thrive. It's because of all the dynamics that are going on in healthcare. Yes.
Representative Emmons next.
Thank you, Mr. Chair. Thank you for your testimony. Just want to comment on your watch band. I thought it was a hospital. I just have a question, just to bring it back to, I appreciate all your points and I agree with many of them. Bring it back to the substance of the bill. I don't know if you have the text in front of you.
I do.
So it seems to me that the crux of the bill is 1G1. And if you could just address that portion
1G1.
How do the points that you made relate to that section of the bill where it's requiring quarterly synchronization of changes, unilateral changes? Does that support your argument, or?
Healthcare carrier shall provide a participating provider facility with 60 days notice for proposed change to a contract, including attachment. To me, it seems impractical and onerous. And we as healthcare providers, we negotiate once a year on our contracts, sometimes once every 3 years, depending on the contract. I see this bill, and it seems innocuous, meaning harmless, but in reality, it would allow them to prevent health plans from being creative in steering patients to lower cost providers or incentivizing them financially.
Further question may inquire.
I'm not connecting the dots on that last statement that you said. How would it prevent them from steering to lower
Because
costs?
it may mean that you could interpret that even though we have a contract for a certain reimbursement rate, okay, and on the other hand, you have a health plan, a plan design that is creating incentives for patients to seek an alternative lower cost provider.
I think he's just saying, what's the difference between 60 days and 90 days? 90 quarterly is 90 days.
Yeah, and I
the
think
current
that's
law is,
and I think
it's gonna
that's
be
very
60 days.
onerous and complicated, because there are hundreds of different procedures and services, and to do that every 90 days just seems impractical to me. I don't think. I think we need less regulation in healthcare. All right, instead of more.
Okay, Representative Spear.
I wanted to go back to my original thing.
Mm-hmm.
And one of the things you say is this is cheaper than that, that's cheaper than that.
Mm-hmm.
But as a person, and everybody I know, when they seek health care, they never ask that. They ask, where's the best one I can find? Who's the best doctor? Who do you know is the best? And that's where I'm going. So in your model, I don't see that.
Well, if I knew ahead of time that I chose a provider that was about to bankrupt me, I would like to know that. Okay? And at the same time, a lot of people don't ask because they're not paying for it. Their employer's paying for it. Okay? And we got to get away from that. All right? We need more personal responsibility and education as to what our decisions or what decisions are we are making that actually can affect you, not only in a healthcare wise. Now, interestingly enough, on quality, you can get on the internet and you can get pretty good darn information on through Google reviews of providers and their information, okay, as to the quality of their provider. And the fundamental problem in all of healthcare, unfortunately, is people don't have a doctor like many of you had as a child. Families don't have doctors anymore. They get teams now. They get they get someone else. Anyways, if you are in the hands of an independent physician, you are less likely. You're more likely to save money than you are if you are in the hands of an employed
Again, you're
physician.
referring to the other bill, not to this
Right.
one. Okay. Thank you. It's always a pleasure seeing you.
Same here, John.
Take care.
Thank you.
Okay. Chair, we have 3 cards left. Are all insurance related, companies related, in opposition to the bill. So we'll start with Sabrina Dunlap from Anthem.
Morning, Chairman Hunt and members of the committee. Thank you for the opportunity to speak. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem Blue Cross Blue Shield. We are respectfully opposed to HB 1813 for a number of reasons. I did want to say first, we appreciate that Ben Bradley from the Hospital Association engaged the carriers last year. They had the same bill in the Senate. The Senate found it inexpedient to legislate, but we do always appreciate engagement from people on bills. So just wanted to say thank you for that. We have the same concerns that we had last year, so we do hope this committee will not move forward with this bill. I wanted to just ground us in a couple of things around provider contracts and their various attachments and ancillary documents. There is an underlying contract between the parties, the hospitals, for example, and a health insurance company. It spells out the standard contract terms, but there are typically a number of attachments and or ancillary documents. This is often in the form of schedules or exhibits that might need to be updated because of changes in rules or regulations, while the fundamental elements of the agreement itself do not change. This is a widely accepted concept of basic contract law. In a number of these documents, the parties retain the right to make changes and updates. One of the most important documents in this context is the provider manual. Although I would note this bill does apply, it is quite broad. It does say the contract and ancillary documents. But provider manuals are used to provide guidance to providers on a wide range of issues, including claim submission, reimbursement policies, and utilization management, or which helps ensure that members receive the appropriate quantity and quality of healthcare services delivered at the appropriate time and in a setting consistent with their medical needs. One of the ways we help manage is by updating clinical guidelines in the provider manual. These guidelines might be based on changes in clinical best practice for certain services, and it's essential we maintain the ability to make these updates with appropriate notice to providers. I just want to note these are not unilateral contract changes. We've heard it characterized this way in the past. There's been several iterations of this bill. These are changes contemplated by both parties when they negotiate and sign the contract. And just getting to the language of the bill, I think it seems unworkable and sort of at odds with reality that we would be able to anticipate any and all changes on a quarterly timeline. We do give 60 days notice of changes. That's already in statute. But again, this bill would limit that to quarterly updates. It also would require red line changes. It just seems like quite a bit of overreach when you're talking about negotiations between two parties. I do want to flag a similar bill passed in Maine. I think it was last year or the year before. Parts of it have been, what I understand is essentially sort of unworkable. They had a similar provision around estimating the cost impact on providers. I think that section is quite puzzling. I won't repeat what Michelle Heaton from the department said, but it's unclear how we would possibly make those estimates and what they would be used for. I would also note in Maine, the bill is narrower, or the law, it did not apply to the underlying contract in all related documents. It only applied to the provider manual. The New Hampshire language is quite broad and would apply to the contract and any attachment. I also just want to note, I think there's some confusion around member benefits as opposed to the provider manual. We don't make mid-year changes to member benefits, certainly not through the provider manual. Those are dictated by a member's certificate of coverage. So those would not be changed. I think that sort of gets confusing. I have some other suggestions on sort of the language of the bill. But again, we do think the bill's unnecessary. We think it interferes with how health insurance companies and providers negotiate contracts and conduct business. And so we are opposed to the bill and hope you will find it inexpedient to legislate. Thank you, and I'm happy to take any questions.
Yeah. Representative Purcelli.
Thank you for taking my question. My quick question is, so could patient care be interrupted if there are these mid-year changes? I just want to understand that a little bit better.
Thank you for the question. The answer is no, patient care would not be disrupted. If, for example, somebody was receiving, I'll say, PT at a hospital setting, and there was a change to the provider manual given with notice that would encourage members to go to lower cost non-hospital settings when it was appropriate. If a patient was already in the care of someone at a different provider, it would not be disrupted. There are actually also separate statutes around continuity of care for members. So changes to the provider manual do not cause disruption to members.
Representative Emmett.
Thank you. I'm just trying to get my head around the current state and the proposed future state. So currently, if you're going to make a change, you have to give 60 days notice. Can you make that change any time of the year, just as long as you provide the 60 days notice?
Thank you for the question. My understanding is that in most of Anthem's agreements anyway, we negotiate the contract, and it does specifically say that we can make updates to some of the ancillary documents like the provider manual if we give 60 days notice to the provider. I believe that's also in what is a pretty lengthy statute governing contracts between carriers and providers.
Just follow up.
Further question?
I'm trying to understand what the dynamics here. This bill proposes a set schedule of updates every 90 days, right? So you'd have 90 days notice you'd have 90 days to anticipate changes, and then you would do it quarterly, and it's so everybody's on the same page of when those changes would be proposed, and currently it's 60 days notice whenever you need to make a change. This would be, you would know ahead of time when those changes can be made, and everybody would be on the same page. Is that
Thank you for
not
the
true?
question. I think so. Just to make sure I understand, current state, yes, we give 60 days notice, and under this bill, we would be required to only give notice 4 times a year. That says January 1st, April 1st, July 1st, October 1st, and I think, you know, I understand that that could be seen as not that big of a change from having to give 60 days notice. I just think in the reality of what this looks like on the ground, and the need for a dynamic process, it is quite burdensome, and I think difficult to sort of anticipate and plan around that sort of set schedule. And we do think that, you know, putting something like that in statute is really quite a bit of overreach. These are negotiations between 2 sophisticated parties, so we just don't think it's necessary in light of the existing regulations on these types of contracts.
All set? Yeah, so let me just kind of summarize. So on January 28th, you finally come to an agreement of what the change is going to be. And so you wait 60 days. Oh, that's going to be February, March. Oh, we got to wait till April 1st before we can implement them. So I guess, would you believe that as someone who is shocked to see that the contracts get muckied around during the year, and how many times I've heard from insurance companies say, please put off the effective date when we have the new contract cycle, okay, that it somehow there's a part of me that thinks that having things happen on the 1st of a month is probably better than having on the 23rd, that's the 60-day cycle. And that way that every provider knows that on these key dates, if there was a change, that they need to be thinking the fact that these dates are effective dates to have change.
I know
Would
that
you
was,
believe
would
that?
you believe, could I respond
Yes.
possibly? Or Thank you. I just want to clarify that I hear what you're saying, but I think we do have the underlying contract that is negotiated between the parties. That doesn't change unless it's specifically reserved in it that either party could propose some sort of amendment. We are talking about the ancillary documents. So it is widely accepted in business that oftentimes you need to have sort of documents that are more nimble attached to the underlying agreement. And that is what we're talking about. And so I also just want to say this is not some, secret nefarious thing. There's a lot of communication that goes on between the parties. We want the providers to be informed. So I think the process currently works well. It may not be perfect. I just don't think putting in these sorts of set dates does anything to really help the situation. So
Great.
Thank you.
Thank you very much. Okay, just what
Thank
I
you.
said, I'll had just 3 cards. Another card appears and doesn't even have a time on it. So let's keep it to 2 to 3 minutes, and hopefully you even have a printed thing. That's great. So
Thanks, Mr. Chairman.
So you're
Thanks for the opportunity to testify on this bill. As I noted, Ben Bradley with the New Hampshire Hospital Association. I want to thank Representative Miles for prime sponsoring this bill on our behalf. HB 1813 takes a measured approach to establish predictable, transparent, and accountable standards for mid-contract and provider manual changes with licensed carriers in New Hampshire by amending RSA 420J8. I hear from our members about unilateral carrier changes to provider agreements more than any other issue by far. By way of background, commercial health insurance payment systems are primarily based on HIPAA-required coding sets, which are periodically updated, and as a result, contracts between providers and health insurance companies allow for mid-year provider agreements, policy changes to adjust coding in alignment with mid-year changes made by the American Medical Association and other governing bodies. Mid-contract changes made by these entities are generally technical in nature, and they historically do not represent significant changes with a material financial impact. However, in recent years, health insurance companies have begun implementing mid-contract policy changes to their agreements and supporting documentation, including what is known as a provider manual, which do have a material impact on the provider and can impact patient care, as noted by the sponsor. In other words, providers negotiate a contract with a health insurance company, then the carrier later unilaterally issues a policy change that materially impacts the financial outcome of the contract. The provider has little opportunity to dispute the change other than a nuclear option to walk away from the contract. And I think we can all agree that would be highly disruptive and not in the interest of patients. Our members have attempted to privately negotiate protections against this behavior unsuccessfully. Now to the bill. HB 1813 would do three things. Line 3 through 12 addresses the cadence of changes as it's been pointed out. Imagine the multiple carriers, right? We contract with dozens of carriers in the state, each making changes anytime during the year becomes extremely cumbersome and difficult to comply with. This proposal allows health insurance companies to make those changes with 60 days notice, which is current law, only 4 times per year on a set schedule, January 1, April 1, July 1, and October 1, with some exceptions that I would point out that we've made very important to accommodate those traditional changes. This provision simply asks health insurance companies to plan their changes around a predictable timeline. Line 13 through 17 is around tracking those changes. Unfortunately, when health insurance companies make changes to the provider manual or any other element of a provider contract, the changes are not clearly highlighted or identified in original documentation, often resulting in significant time and research by the administrative resources to try to determine exactly what has changed. Imagine trying to do your job in this committee if all you were handed was a replace all for a 100-page complicated statute change. No underlines, no strike-throughs, no page numbers. It's a nearly impossible task that sometimes providers are unable to keep up with, and therefore, when claims are submitted under old policies, they're denied and left in dispute or unpaid. This provision aims to reduce the administrative burden created by these changes. And finally, on good faith estimates, these companies claim these changes are mechanisms for implementing evolving coverage and emerging industry standards, as well as managing costs in health services. This section would require health insurance companies to provide a good faith estimate of the financial impact of the changes to their contract if in aggregate it was more than $500,000 a year. The goal of this provision is to quantify the financial impact of these changes and be transparent about health insurance companies' management of healthcare costs. It would be hard for me to believe these companies make changes to provider manual policies without financial considerations. This proposal simply requires them to disclose those considerations with the department and providers impacted. I'd argue that the administrative cost for health insurance companies to comply with this provision is negligible or non-existent because any costs could be accounted for using the financial gain from the change itself. Therefore, there should be no upward pressure on premiums. In fact, it should lead to shedding light on how health insurance companies have managed costs and to lower premiums. Lastly, very similar bills, as was noted, a very similar bill was passed in Maine, and all we're asking are for the same protections here in New Hampshire. I'm happy to take questions and address any of the suggestions that have been made in previous testimony.
We also heard that this bill was in the Senate last year, and the Senate didn't pass it.
Correct.
So what's changed, or what's different, or what's going to happen differently than if we were to pass it? They'll say, "Oh wait, we already killed this. Why would we want to even take it up?" I mean,
Well,
what has changed?
I don't think the House would concede to the position of the Senate on all matters if they felt it was an important proposal to move forward and reconsider in a subsequent year, and that's why this bill has been reintroduced.
But would you believe generally, if one body kills something in the first year, they really don't want to see it the second year?
That may be the case, but I think this, as I mentioned, is an issue that we hear from our providers the most by far, and it's a timely issue that we feel is a small ask to have this on a regular cadence that can be predictable for providers and patients.
Fair enough. Any other questions? None? See none? Okay, now I have just two cards left. Representative Peter Bragdon of Harvard Pilgrim, and all I can ask is, Peter, be brief, and please do not repeat anything that's already been said.
Thank you, Mr. Chairman, members of the committee. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare. As the chairman said, the state's non-for-profit health insurance carrier. A couple of main points here. A main question for you all is, why is the legislature getting involved in a contract between two private companies? Carriers and providers enter into contracts. The contracts dictate when and how changes can be made. If the parties want to change, they negotiate. This bill is weighted to only one side of the negotiation, that being the side of the providers. Rather than negotiate, they want the legislature to put their thumb on the scales. So question number one, why getting involved? With respect to quarterly changes, we're a small, nonprofit regional health insurance company. We're not one of the big behemoths. We don't own all these other companies. We're a small regional health insurance company. We operate in 4 states. Our systems aren't designed to implement different effective dates in different states for various policies. What happens, Maine recently passed a law, as was noted, that required only quarterly changes. In Maine, we have to go in and manually review and edit claims, every individual claim, to see if it comports with the policy. That is labor intensive, time consuming, and adds to administrative costs. We would also then, obviously, if we can only change 4 times a year, not be able to fix grammatical or typographical errors. So let's say a couple of zeros were added to a price accidentally, we wouldn't be able to change that. Maybe the word not was accidentally left out and should have been in there, or vice versa, not be able to change that. Which reminds me, there's a great story about a printing of the Bible that missed a word in the 10 Commandments. We'll talk about that offline. It's called the Wicked Bible. Let's see. And doing a little math here, unfortunately, I have a degree in computer science and a minor in math. Yes, it says 60-day notice, but let's say it's November 2nd. If it was November 1st, we could get a change in January 1st. If it's November 2nd, we have to wait until April 1st. That's 150 days. So if there are things that need to be addressed, it's not just waiting a few more days. It's waiting 5 more months. And then next to last point is that last section of the bill talks about the cost to providers, lines 18 to 25, requiring us to calculate the cost to providers. I'm told by providers that they build their budget estimates based on their estimate of the amount of usage a certain service will get. We're not privy to that information. It's almost impossible for us to figure out what it's going to cost each individual provider for this. And I guess taking a whole step back and hearing the testimony and putting a few pieces together, I think one of the things that is probably driving this is based on prior conversation with providers and some of the testimony today. The provider manual is a part of this. The provider manual tells things like when prior authorization is required. So let's say Nick Vallis moves next to town and Peter Bragdon owns a hospital. And my hospital, according to Nick, charges $5,000 for an MRI. And Nick Vallis moves down the street and charges $700. And the insurance company says, okay, if you're going to charge $5,000 for an MRI, we need some prior authorization to make sure that there's some special reason why you're doing that. We will need to change our manual. This bill would not allow those changes, which I think is kind of drives what Nick is saying. The innovation is there. Someone new moves into town, offers a new service. We need to be able to find a way to not for the next 5 months be paying $5,000 for every MRI, but to either steer people to the $700 or talk with the provider and say, okay, we need to do something about the price here. This takes away all that pressure. So for all those reasons, Harvard Pilgrim is opposed to the bill.
Thank you for helping explaining Nick's testimony.
This is not the first time I've heard this. It's like a Groundhog Day.
Yeah.
Okay.
So how often does the manual get changed?
I don't know for sure how often the manual gets changed. I will say the Harvard Pilgrim provider manual is online, and I browse through it last night in my copious spare time. And at the bottom of every page, it says when every particular thing was changed. And I didn't say, and of course it goes back, some of them go back 10 years. And so some of them there were 5 changes and some of them there were 20, and they're scattered around. Sometimes there's once every few years. And depending on what kind of things need to be changed, depends how often Nick's going to open up new facilities, I guess.
Fair enough.
Am
Any
I
other
allowed
questions?
Am I allowed to would you believe?
They're not supposed to, a sponsor, you're not supposed to ask questions. So. But we would believe it. Thank you very much. Okay, one card left. Paula Rogers. Mayhip.
Good morning, Mr. Chairman, members of the Commerce Committee, House Commerce Committee. Thank you for the opportunity to say something very briefly. Of course, like you, have listened to all the testimony. But I remember not only last year's bill, Chairman Hunt, but I think maybe 4 or 5 years before, there was a significant bill that also got into the provider manual and its relationship to the underlying contract between a carrier and an insurer. And I too, like Peter Bragdon, have been online looking at provider manuals, and they're voluminous and they cover an array of things. But the provider manual and maybe some other auxiliary documents have been part and parcel of contracting for quite a long while. When I listened to Ben Bradley, he sort of suggested that something has become amplified recently that makes the kind of the abrasion of that contract, the provider manual adjustments, more significant. But I really don't know how to put a finger on what that is. So I certainly understand where Representative Miles is coming from. It would be nice if there's something chaotic going on to bring a rhythm to it. But you've heard the carriers, both Anthem and Harvard Pilgrim, and you may also have others that have signed up, I don't know. They don't understand the need for this. They think that the arrangement works well. The 60-day notice is there. And so basically, that's why I signed up sort of saying, I think sort of in between the line, because I know there's abrasion there, and I hate to come in and say we're seriously opposed. We are opposed. But I can understand the other side of the issue as well. And so I'll leave that to you because you're the ones that make the decision as to whether you've heard enough that something needs to be done this year or not.
Okay.
So, thank you.
Thank you. Any questions? Seeing none, we'll close the public hearing on 1813. And last one this morning, House Bill 1638, creating a bypass mechanism for health insurance step therapy protocols when medically necessary. And prime sponsor, okay. Good. This, you did give me a card. You're on top of the pile. Good morning.
Ready?
Still morning.
Sorry, I've been running back and forth between the office. It's been a fun morning. Thank you, Mr. Chairman. Thank you, members of the committee, for listening to our testimony. Today, this is on House Bill 1638, which we're also calling the Step Therapy Reform Bill. I'm going to do something very strange and just tell you right off the bat that I've been trying for months to create a work group to work on this bill, which for a variety of very good reasons has not happened. The insurers, myself, the insurance department, and all involved do feel that this bill deserves more work, and we're going to ask you to consider interim study for it. With that said, I really think it's important you hear what we have to say first. So we're going to proceed. I brought this bill up on behalf of the Susan Komen Foundation. the New Hampshire Rare Disease Advisory Council, and the National Organization for Rare Diseases. I would be remiss if I did not mention Nancy Biederman, who will be speaking to you later, who's very passionate about this bill, and she's done a wonderful job of bringing this to everybody's attention. So anyways, you'll hear from her. The bill is also supported by the Med Society, New Futures, and the Every Life Foundation for Rare Diseases. In your packet, I actually gave you the federal version of this bill from Senator Markowski, and this is not this year's version, but the reason why I handed this to you is if you look at the second, third, and fourth pages, it lists all the organizations that sponsor this type of, or endorsing this type of legislation. So it's very important at both the federal and the state levels. I will also add, this is not new legislation. This exists already in 39 states. If you look at the back of the packet that I handed you, there's a map that lists anybody in blue already has legislation germane to this. So this is not a new thing. New Hampshire is actually one of only 11 states that doesn't have legislation. And on page 4, I actually listed it out for you because I really needed to do it for me as to who has it and who doesn't. I also would add, if you're interested, this is a thorough review of the topic, cost benefit, all that stuff. And it's on the reference is on what I gave you. But if you want the copies of it, I can leave this one with you. So the first question, what exactly is step therapy? And I don't know where that term came from, other than in 1986, the World Health Organization released a thing called the analgesic step ladder. And it's really important because it defines how we as healthcare providers make clinical decisions. What they did was they were focusing mostly on oncology patients, but how do you prescribe or give pain medication or other therapies to somebody in pain? And they used a variety of criteria and then a variety of steps. So the first step was like for mild to moderate pain, you would do certain things. For more severe pain, you would do something else. For other severe pain, you would do something else. And you had options. You could pick the step you wanted to choose, or you could go in order depending on the individual circumstances of the patient. We still use that today. It's a really important model, and I think that's where the term step therapy came from, and people behind me can tell me if I'm wrong or not, but that's not what step therapy is as the insurance companies use it. What step therapy is for them is more of a rigid thing. The people it's called a fail first policy, meaning that in order for a specific problem, you have to take a certain drug that's relatively inexpensive. If you fail that, then you can go to the next, and then the next, the next. There's a lot of problems with that, not the least of which is, what does fail actually mean, and how long do you have to determine you've actually failed it before you can go on to the next? It also flies in the face of what we call patient-centered care, which means that we treat every person like an individual. And what may work for one person may not work for another. They are blamed as using cost as the primary motivator for choosing what goes where in this step. I'm not totally convinced that's true. I give them a lot more credit. I think there's a lot more complicated thought that goes into it. I think cost, relative risk, invasiveness, and evidence base all play a role. So I think that's important to know, but at the same point, it's still very rigid. It also differs from prior authorization in the sense that you don't necessarily need a prior authorization to do step 1, step 2, step 3, but you can't go from step 3 without doing step 1 and 2 first. So there doesn't necessarily need to be an authorization process there. Anyways, why is step therapy a good idea? I think we heard a little bit earlier today that cost containment is not something doctors do well. So oversight is necessary. It's like really important, and I think it is important. However, the whole system falls apart for a variety of reasons. First of all, there's not often a lot of transparency to this process. We don't really know what the rules are, why they came up with this order, sometimes what even the order is. And there's, in a lot of places, the transparency is an issue. The process also assumes that there's a clear evidence base to determine what the treatment order is. There's a thing called the Cochrane Collection in Scotland. It's the largest collection of evidence base in the world. Somebody had nothing better to do, decided to look at 1,100 clinical questions referenced in the Cochrane base, and they found that only 3% of the medical questions are clearly answered without a realm. So that leaves a lot of subjectivity to deciding what evidence base is and makes us really more subject to best practice. The more complex a patient's problem is, and that's kind of what we're talking about here, the more likely there is no evidence base. It's a one-size-fits-all strategy, and a lot of times you're putting square pegs in round holes, and that is a problem. We went over evidence base for patients with serious diseases like metastatic cancer, which is mentioned in this bill separately. Thinking outside the box is necessary, and arbitrary decisions like this can be fatal. Many patients do not tolerate various therapies or other factors, and following these protocols for some people can be harmful. Many patients, this is where we get beyond the serious and the rare. This is where we talk about everybody in this room, but many patients have already tried the other steps first, but then they change insurers. When they go to their insurance, some of them require that you go through the steps all over again, which really makes no sense to me. And there is no clear evidence that this actually controls cost. And that is referenced in this article. I will leave that to you to review because that goes into great detail. But there's actually no evidence that step therapy does control cost. Furthermore, there is evidence that maybe there's a short-term cost reduction for the insurer and for the system, but there's ample evidence that long-term costs and risks are actually increased. And we don't tend to think in the long term, which is problematic. I will not get into the ethics of this. That's another thing. So what does 1638 do and what does it not to do? It's important to emphasize it's not designed to replace step therapy. I think step therapy protocols do have value. However, for some patients, they're not the right thing. And so what we want to do is give an appeals process to bypass steps when necessary. And that's pretty much what every state does and what the federal government is trying to do. Nobody's trying to get rid of these things that I'm aware of. I did review a lot of states' policies to come up with this one. The reason why we chose the Maine law was because I could read it, I could understand it, it made sense, it was thorough, and it was very similar to what most of the other states do that have already passed. The federal bills that I referred to, there's one in the House, one in the Senate, are very similar to what we're doing here. The Senate bill focuses more on ERISA, the House bill's more on commercial insurers. So they do create an appeal process. It does not need a new mechanism for this. When we passed SB 561 2 years ago on prior authorization reform, we basically used the same language to define this process, so nobody has to create something new. It does create transparency. It does create timeframes, which we don't necessarily have now, and that is what we created for prior authorization, which I think was important. It does apply only to pharmaceuticals, which me for personally is a problem, but that's something we can deal with later. It creates a clear process by how these protocols are developed, because we need to have a lot of input into how that happens. And it creates a process by which protocols are updated. It demands that atypical populations who you're going to hear from in a second are treated. I'm talking about people with rare diseases that don't follow the rules or people with complex disabilities. And it also eliminates step therapy protocols for patients with advanced metastatic cancer or an associated condition. The process is still overseen by the insurers. They still maintain most of the power in this, which I have mixed feelings about, but I personally believe oversight should be multi-stakeholder, but that is what this bill does. And I think that's all I have. And if you have any questions, I'm happy to take them.
I guess that was a very straightforward testimony.
Thanks. And I will reiterate, we would like to convene a work group this summer like we did for HB 241, which you heard earlier this year. To finalize, put this together and make it in a position that everybody's happy with it. So
Right.
that would require an interim study, I believe, correct?
Well, we would, yeah, interim study, correct.
Thank you.
Okay. Nancy Biederman.
Good morning. Representative Nagel is very sweet. I've been pestering about this bill for about 2 years. So this summer I met with him and brought all the documentation and said, let's do it. And he's been doing all of the legwork since. It is sad to note that we are the only New England state that doesn't have this bill. Massachusetts has it, Maine, Vermont, Connecticut. So when you hear the insurance companies, because I saw the sign in and they're both against this, they're doing it in other states. So there's no reason they should be against this if they're already doing it in other states. Yes, this federal government did put across a bill. Even our own Senator Hassan, is also listed on that bill. But it's just sitting there. It hasn't been brought to the floor. So, nothing is happening with this bill. Just to let you know, I am on the Rare Disease Advisory Council for New Hampshire. I am representing myself, not the council. I've been on the council since 2024. And I've been fighting for rare disease patients and advocating for them on multiple bills. There are 7,000 rare diseases. In order to be considered rare, under less than 2,000 Americans have to have it. 25 to 30 million Americans are affected. That means 1 in 10 people in the United States have a rare condition. Many of them don't even know they have it until they're in a serious medical situation. 95% have no treatment at all. 95% of rare diseases have no treatment. And so when you have a rare condition, as my family tends to have tons of them, you go to the doctors looking for help. And hopefully you have a doctor that knows your rare condition, has heard it and has treated it, and possibly knows what drugs will work and which ones don't. And then when you go there and the doctor prescribes, hey, this is the drug, I think that'll work with this situation that you're having with this condition. And then you get a letter from Anthem Blue Cross that says, sorry, you cannot have the drug your doctor prescribed. And this is what they say. We deny your request because we do not see what you need to approve the drug you asked for. We may be able to approve this drug when you've tried these drugs first. 2 of the following preferred drugs. This is for my daughter. She has multiple rare conditions. She has to fail at 2 drugs before she can get to the one the doctor prescribed. Now, we've already gone down this road once before. We've done this with her migraines. And you will hear, if you go on the House and look at the testimony that's been submitted, there's other people that have written in their stories about drugs and what has happened to them. It is very scary when your doctor prescribes a drug and that afternoon after you take it, you are rushing to Mass General because your daughter's having that severe reaction. My daughter almost lost her eye because of a reaction to a drug, because we had to try it first. And then at that point, we needed to wait another 3 months in order to get into the doctor, because it takes 3 to 6 months to get into any specialist. And then in order to then try another drug that we're going to have to fail at. She is finally on the migraine medicine that she should have had to begin with. But that took almost a year to get onto that drug, where she again had a rush to Mass General, where the head trauma doctor down there thought she was having a stroke. So when the insurance companies tell you this is cost effective, I don't know how it is cost effective when we're having multiple emergency room visits to get treatment for these. Just to remind you, this is Rare Disease Month. February 28th is Rare Disease Day. Just think about this when you get this bill, when it comes out of an interim study. Any questions, concerns?
Seeing none, thank you for
Thank you.
sharing your story. Angelica Katz.
Good morning, Chairman and members of the committee. Thank you for the opportunity to testify in support of House Bill 1638, which does put guardrails on harmful step therapy practices and further protects metastatic cancer patients. For the record, my name is Angelica Katz, and I'm the Senior Regional Manager for State Policy and Advocacy for Susan G. Komen, the world's leading nonprofit breast cancer organization. I already emailed my testimony over, so I'll just highlight a few points from that. I know Dr. Nagel already went over what step therapy is, and so I won't repeat that. But part of this bill, which he did mention, addresses eliminating step therapy practices for metastatic cancer patients. So I just want to go over why that's really critical. So metastatic breast cancer is advanced stage breast cancer. It's where tumor cells have spread to other parts of the body, such as the bones, the liver, the brain. Nearly 1/3 of women diagnosed with metastatic breast cancer in the U.S. live at least 5 years after diagnosis. It cannot be cured, but it can be treated. And there are actually multiple treatments for the disease now that exist. We have advocates that have been living with metastatic breast cancer well over that 5-year range. So it can, like I said, it can be treated. But those treatments are highly personalized, and they must be based on the decisions between the patient and their healthcare provider, since they are the most capable of determining what treatment that they need. So unfortunately, in step therapy policies, they're particularly really burdensome for metastatic cancer patients. And I know, we're a breast cancer nonprofit, so we are representing breast cancer patients. But once something becomes metastatic, it is just metastatic cancer. And also step therapy protocols, they usually rely on very generalized information regarding a patient and treating their disease. However, with metastatic cancer, it has to be very specialized treatment. Financially, a recent study published found that implementing step therapy protocols could actually increase the total cost paid by the insurer by 37%. Additionally, according to a study published in the American Journal of Managed Care, step therapy may create barriers for patients receiving their medication and ultimately result in higher medical utilization cost. These protocols should optimize affordable, effective, and appropriate access to care and not lead to delayed treatments, poorer patient outcomes, and increased medical costs. I also have fiscal notes from other states just reflecting the metastatic piece. Maine just recently passed this last session. Louisiana, Oklahoma, Maryland, Colorado. These are all states that have shown very minimal fiscal impacts to premiums. And also, I'd just like to end with, we're here to ensure that patients are receiving consistent and effective treatment. And this bill would really help to eliminate any type of barriers that they will need to, to access their life-saving medicine. So with that, I'll finish my testimony, and I just urge you to strongly support HB 1638. Happy to take any questions.
Thank you very much.
Thank you.
Appreciate it.
And apologize for the voice. It's that time of year. Thank you.
Okay, change pace. Michelle Heaton from the New Hampshire Department. Insurance Department.
Sorry, it's driving me crazy.
Okay, you're in charge of that from now on.
Michelle Heaton, the New Hampshire Insurance Department, Director of Life and Health. We are neutral in this bill, but we did want to point out some things. This bill, we're not really sure that we need it. I think a lot of what everyone is getting at in this bill is really already required under our law. However, we recognize that some of our laws and rules can be difficult to decipher. And so that's why what we're trying to do right now is revamp our utilization review rules, INS 2000s. And it's going to address a lot of these things to try to streamline the process. So I'm just going to go through a couple of the big things discussed in this bill and tell you what we're already doing about it. So with respect to clinical review criteria, this is already required to be based on evidence-based when there is evidence. If there's not, then there's like a kind of a checklist you go down of the different ways that you would do this. With respect particularly to prescription drugs, that needs to be looked at by the P&T committee, the Pharmaceuticals and Therapeutics committee that every carrier is required to have. And that committee is made up of pharmacists and doctors specializing in a variety of different areas. They're required to look at all of the clinical evidence out there as they're developing formularies, putting in prior authorization or any kind of utilization review requirements or any step therapy. So all of those step therapy and prior auth, all of that would be in their clinical guidelines, and those clinical guidelines need to be supported by evidence. They can't just make up something out of nowhere. It has to be supported by something. And that is part of what we do at the department, is making sure that they have done that they are making those decisions based off of clinical evidence, studies, evidence-based, clinical guidelines, whatever's out there that exists to support their position. With respect to actually being able to access step therapy, we do have reference to it in our new rules, just clarifying some of the requirements and making sure that when the forms are being submitted, there's an opportunity to, clarify that this is a step therapy issue and help the provider identify what the patient has already done. But we would consider this usually under prior authorization because you're requesting access to something. And usually that's, if you want to bypass something, you're going to have to get a prior auth for it. It doesn't mean you can't do it. It just means that you need to do that request. And as you know, we, a couple of years back, passed more legislation to really streamline the prior authorization process. We're still in the process of implementing that, but that's part of what we're doing in the 2000 rules, is really trying to get all of these requirements in one place so it's very clear what the requirements are for the carriers and for the providers. And I know some of the testimony we heard, oftentimes when we see these issues come up, it's not that the carrier is denying access to the medication, it's just that they need more information. So oftentimes if you have tried these other things and failed, that would be in your medical records. So usually the carrier is requesting those medical records that'll show, yep, you already tried that, or you're not tolerant to that. That's not going to work for you. So that's part of the process of what the carriers are looking at when they're doing these reviews. And sometimes it's just, everyone's busy. I'm not going to blame anyone, but sometimes these requests get submitted and not all the information's there. That's again why we tried to open up peer-to-peer review, to make it easier to have these conversations at any point in the process rather than waiting for the denial. But if there is a denial, you have an appeals process. You have the option to go to external review. There's a lot of these remedies already in our law. And, based on some of these conversations, I think that we need to do maybe a better job in making sure everyone's aware of what the law is and how to access these remedies for them. I think that's a lot of what's in here. I'm trying to think if there's anything else. Especially with prescription drugs, the timelines are even narrower than for the other medical services under prior authorization. And we already have an exceptions process. But that's usually more for drugs that are not on the formulary, not utilization review, but it's essentially the same type of process. You need to submit the clinical reasoning why you need access to this drug. There should be medical records to support it. And then the carrier is going to review all that and make a decision. If the decision is a denial, then there's the opportunity to appeal that decision, and someone else within the company is going to do a fresh look at everything provided and do another one. If it's still a denial, then the person can go to external review. It sounds like these are lengthy processes, but there are expedited processes for all of this. So if it needs expedited review because it's a serious medical condition that you need access to this care right now, it's 72-hour turnaround, and that's for the initial determination, the appeal, and your ability to go to prior or external review. So we do have a lot of this in place. And I think in hearing some of the testimony, I think it's a matter of just educating and making clear that step therapy falls within all these systems that are already in place. But we're happy to engage in the study committee and make sure that we do have everything that I think we do to address all these issues. And if there are any gaps, we are going to be in rulemaking imminently in the INS 2000s, and we'd be happy to work with stakeholders to address any gaps that are out there.
I'm glad you brought up external review. I think I even remember the bill number 620, since I was the only sponsor, the prime sponsor and the only sponsor. And as far as I remember, I think it was Shaheen who signed it. That's how old it is. And my question is, because I know we got this peer-to-peer bill, we got this, a lot of these things are all coming together here, let alone the pre-existing, the pre-approval. So how often is external review used?
Not very often.
So in other words, we have a place in effect, but nobody gets there. Do these problems get solved before that, or do people just give up? Or,
I'm not sure. And that's part of, what we're trying to do in the department is make sure people understand how their plan works, what their rights are under the plan. And if they really, as we work through our consumer complaints, if this is the type of issue, we always make sure to let them know this is where you're at in the process, this is what you have to do next. You are eligible for external review. You need to file these forms. That's a lot of what we help people through. But I suspect there are, people who just don't understand how the process works and may not even understand. It isn't in their documents, but how many people have actually read their insurance policy lately and understand what any of that means? And so as the department, we are trying to make sure people understand what their rights are. And if they call into our consumer services, we are definitely holding their hand through that process and helping them, navigate that. But overall, we have not many external
How often
reviews.
does people call this consumer?
A consumer, we get thousands of, inquiries or complaints a year just for health insurance. So people are calling in, but it's not always this type of issue. There could be a variety of issues, but I think I'd have to double check, but I think for external reviews, it's between 50 and 100 a year for all carriers. So it's a relatively low number. There's definitely more appeals happening, and I'm not really sure what the reasoning is, but there's definitely probably more the insurance department can do to make sure, consumers really understand how their benefits work and making sure that they're availing themselves of the processes that are in place.
Representative Spear.
Thank you. You went through it pretty quick. So under the prior authorization stuff, you mentioned STEP very briefly, but you didn't mention any kind of a process that says, no, you can go around it this time, that allows somebody to just go around it.
That would be part of the prior authorization process. So you would have your clinical guidelines, and this is just generally for anything. Is if you think of, surgery, I think sometimes that's an easier thing to know. Before you just go and have the surgery, you may want to try PT, you may want to try these different things, depending on what the diagnosis is. And that's why every clinical guideline is a little bit different, but it's the same with drugs. There could be a number of different drugs, and some could be safer, some could be more cost effective. There could be a number of different reasons. And the clinical guidelines outline kind of what you needed to try first or what should be recommended first. And so when you're getting your prior authorization, that is what the reviewer is looking at. What have they tried? And part of that is what the provider submits. They would say, we're trying to get access to drug X. We know that there is these other drugs you're supposed to try first. However, the patient can't tolerate this one. They've already tried this one. Here's the medical records to show it. That would just go right through the process, and they would look at all of that and be like, yep, double checking everything. Yep, you're right. And they would, in theory, provide access to that drug.
But the case I'm thinking of is the case which somebody mentioned before, based on the situation with the patient, they already know what the right drug is. They don't have to try a whole bunch of other drugs. They can go right to the right drug in the first place. But there doesn't seem to be a mechanism to allow them to do that if there's steps in the way.
No, the mechanism would be to get the prior authorization. But part of that is going to that drug is main. If there's clinical guidelines and prior authorization, I'm assuming that going to that drug for everyone is probably not the best way. And so that's why there's prior authorization or step therapy in place. And for some people, that may make sense to go straight to that drug. But for others, you may want to try those other things. And I'm not a doctor, so I don't know what those reasons are, but there are clinical guidelines for that reason. You can always submit a prior authorization request saying, I want to go straight to this drug or this treatment because of X, Y, and Z. And that's why you would submit the medical records to show, maybe they've already tried it or they have an intolerance to something. And you would also be able to request peer-to-peer review at any point in this process and say, let me explain to you why my patient needs this drug. And all of that is already part of the process and required under law.
discussion? Okay. All right. So let's just get Sabrina Dunlap. Because I'll be left with 2 in support.
Thank you,
Since
Chairman
the
Hunt, and
Medical
members of the
Society's
committee.
left, so I won't have to worry about them passing another card in.
I'm Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem Blue Cross Blue Shield. Thank you for the opportunity to speak. We are opposed to the bill as written, but as Representative Nagel mentioned, we have had several conversations with him. Would certainly like to continue those conversations. We have some ideas based on our experience in other states on ways we could improve the language. I think the bill as written would effectively end step therapy. So we have problems with the language as it is written. I would also just say very quickly, as Representative Nagel mentioned, it's not just about cost when it comes to managing drugs, although drugs, especially specialty drugs, are one of the biggest cost drivers in healthcare today. So we do want to manage cost. But there's also a lot of considerations around efficacy and side effects and how long a drug has been around. I will just add that I know I've shared this with this committee before. I do have a child with a rare disease and have lived and breathed biologics and specialty drugs for 10 years and have my own experience with, trying a drug first that has been around a very long time. And there is something to that. A lot of the biologics are amazing. They are cutting edge. With many of them, there's very little known about long-term side effects. So I just want to get in there that there is cost, but there's also many other considerations. And I think if we were given the time to work on this, we could probably come up with something that we think works well. So happy to take any questions. Thank you for the opportunity to speak.
Okay, you got till September to work it out.
Okay, thanks.
Okay.
Have it done by Monday.
I have no illusions of that. Okay. Holly Stevens from NAMI.
Chairman Hunt, it's been a while since I've been in front of your committee.
Nice to see you again.
Yes, it's nice to see you as well. Thank you for the opportunity to testify today. My name is Holly Stevens. I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a grassroots nonprofit organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. We are in support of House Bill 1638. We weren't aware of the recommendation for interim study, but would certainly support that if this bill is worked on and would like to be a part of that. Before I get going with my testimony, I did just want to mention I have availed myself of the external review process, and I will tell you it is a very cumbersome process that even, I know the system and is not something that I look forward to because it takes days to get the information prepared to send to the insurance department. So I just wanted to put that out there that the process is there. It is a cumbersome process to avail yourself of. So I can understand why a lot of people don't do it. A lot of people don't know about it, and the ones that do know about it may not have the wherewithal to be able to put themselves through it. But though finding the right medication regime can be a long and challenging process for folks with mental illness, proper medication can be an essential part of treatment for folks to be living well and healthy. New advances in psychiatric medications and their combination with other services and supports allow individuals with mental illness to lead healthy, happy, and productive lives. Importantly, different kinds of psychiatric medications are often not interchangeable, and providers must be able to select the most appropriate, clinically indicated medication for their patients. Even within similar types of medications, each is unique in their mechanism of action and affect each person and their range of symptoms differently. Patients will respond differently to medications at the start and then throughout and to the end of their treatment. And so when you do find a medication that works, does it really make sense to then say, well, you've got to try A, B, and C before we're actually going to allow you to take D. Individuals with mental health conditions who are unable to access the most appropriate clinically indicated psychiatric medications experience higher rates of emergency department visits, hospitalizations, and utilization of other services. The rates of suicidal behavior and homelessness also rise when somebody's not able to access the proper medication to treat their mental illness. These findings highlight why people with mental illness need continued access to the medications that actually work for them. Step therapy can be a danger to the health and well-being of the person taking the medication and result in worsening of symptoms and undermining the decisions made by the physician. Instead, policies should maintain access to provider recommended medications and should specifically prohibit step therapies, or, as this bill does, provide a clear override exception mechanism in order to go around the step therapy recommendations. You know, when we're talking about mental illness, we're talking about people's lives. We're talking about the risk of somebody taking their own life. And because of that, we do support this bill and think that the decision of what medication should be taken should be between the patient and the doctor and not the insurance company to interfere with that. Thank you for your time.
Great. Thank you.
Thank you.
One card left, Sam Burgess from New Futures.
Morning.
Afternoon, I think.
Afternoon. I know it's been a long morning for the committee, so I'll try to keep this short. Morning, members of the committee, Chairman Hunt. My name is Sam Burgess. I'm the Healthcare Policy Director for New Futures, and we are here today to support the worthwhile reforms outlined in HB 1638. So I want to start by saying that step therapy is a cost management tool. Clinical judgment is a medical tool. HB 1638 simply ensures that when the two conflict, the medical tool wins. Insurer step therapy protocols are designed to reduce spending, not improve outcomes. The American Medical Association reports that 93% of physicians say prior authorization or step therapy delays patient access to necessary care. And more than 1 in 4 say that these policies have led to a serious adverse event for patients in their care. Chairman Hunt, you asked a question of a speaker, I believe two or so ago, that about how these processes play out. I think was the heart of the question. The same survey from the AMA further found that 82% of physicians reported that such policies sometimes or often lead to patients abandoning recommended therapies. Let's talk about cancer. A 2020 BMJ analysis of 1.2 million patients found that each 4-week delay in cancer treatment increases the risk of death by 6 to 13%, depending on the type of cancer. Even short delays in cancer treatment, measured only in increments of weeks, are associated with increased mortality. In this way, the evidence is clear. Delays caused by insurer-mandated protocols like step therapy can worsen outcomes. This bill requires carriers to allow prescribers to request an override when step therapy is not clinically appropriate, based on evidence-based guidelines and a physician's clinical judgment. In this way, this is not subjective. The bill ensures that override decisions must be grounded in established clinical standards, not on whim, not preference, or not convenience. I also think it's important to think about the real-world stakes. When you're sitting on a hospital bed and you're diagnosed with cancer, a chronic disease, or a terminal illness, who do you want determining your next steps? A for-profit corporation like Anthem Blue Cross Blue Shield, whose parent company posted an operating revenue of over $50 billion in the third quarter of 2025 alone, and who has every financial incentive to minimize costs, or a trained physician exercising their clinical judgment to treat your illness safely, effectively, and without delay. The scope of this bill is limited and reasonable. It doesn't ban step therapy, as we've heard before. It simply ensures that insurance red tape doesn't stand in the way of widely accepted, FDA-approved medical treatment or delay care to the sickest patients. When step therapy conflicts with established medical standards, patients should not pay the price. I think there's one more important thing to note. I think we've heard from earlier from Blue Cross Blue Shield that this bill would effectively end step therapy. That flies in the face of what we're seeing across the country. As the sponsor noted at the beginning, 39 states have now passed step therapy laws requiring medically necessary exemptions. I also want to point you to there's a document appended to my testimony. It's at the back. You'll see a graph and a chart. In reference to this document, I'd like to also to say that in 2022, an alliance of over 200 patient and provider organizations conducted an analysis of annual premium increases or decreases between states with and without step therapy reform laws. Significantly, they found that there are no differences between the change in average benchmark premiums in states with and without step therapy reform laws. None. I know we've been talking about cost and how the knock-on effect is going to have on insurance companies. So I think those numbers are pretty important in this conversation. With all that said, and in light of the conversation about interim study, we respectfully request that this committee support an interim study and ultimately support the efforts laid out in HB 1638. Thank you.
Okay. Any questions? See none.
It was circulated, yes.
Okay.
Yeah.
All right. All right. Having no more cards, and anybody else want to speak? Seeing none, I will close the public hearing on 1638. 125.
145.
Okay. So your schedule, how's that? Right, that you have. Okay. And how long do you think it's gonna last, or? Okay, so you'll be here 2:30. Okay, perfect.
We have fewer availabilities. The answer is always we have it's like I think that, like, to your point, the best thing to do at this point would be to hear them out, let them look through them, and understand where they're coming from, so you can really just highlight the differences between what's out there and what they're claiming arguments is, right?
Yeah, I don't, and I personally believe step therapy and prior authorization, while they're not mutually exclusive, they're not the same thing either.
No.
And
Certainly.
I really, I was struggling with trying to, what I did do when I created the prior auth bill was to create the mechanism, and we've used the same mechanism for both, so they don't need to recreate a mechanism.
All right. Okay, we'll open up the public hearing on House Bill 1406. And here's the Representative Gray. Good afternoon.
Good afternoon. How are you? Still snowing outside? All right. Good afternoon, Chair and a few members of the committee. I'm here today to introduce HB 1406, legislation that addresses a critical and rapidly emerging threat to patient care in New Hampshire. Oh, thanks. The use of artificial intelligence by health insurers to override the clinical judgment of physicians and healthcare providers. Across the country, health insurance companies are increasingly deploying AI algorithms to review and alter medical claims, not to assist human reviewers, but to replace them entirely. These systems are processing claims in as little as 1.2 seconds per claim, making it impossible for any meaningful human review to occur. The consequences are alarming. In 2023, insurers denied nearly 1 in 5 claims, up 17% from just 2 years earlier. United Healthcare's denial rate for post-hospital care more than doubled between 2020 and 2022 after implementing AI algorithms. And when these denials are challenged, 90% of them are overturned on appeal by federal judges. This isn't a story about AI making better decisions. It's about AI making wrong decisions that delay or deny medically necessary care. At the heart of this legislation is a fundamental principle. Clinical coding decisions should remain with the clinicians who actually examine and treat patients. HB 1406 takes a clear stance. When a physician codes a patient visit based on their examination, the complexity of care provided, comorbidities present, and time spent with that patient, that coding reflects their clinical judgment. This bill prohibits health insurers from using AI to change, alter, or amend those clinical coding decisions. Let me explain why this matters. First, AI lacks clinical context. Algorithms cannot interview patients, perform physical examinations, or understand the nuanced interplay of multiple conditions. A doctor who codes a visit is exercising medical judgment based on direct patient care. Courts have found that insurers are using AI to override determinations made by patients' own physicians about what care is medically necessary. Second, accountability requires human responsibility. When AI systems change a provider's coding, who is accountable? The programmer, the insurance company, or the algorithm itself? By protecting providers' clinical judgment from AI interference, we maintain clear professional accountability for medical decisions. Third, AI can perpetuate bias and errors. AI systems are only as good as the data they're trained on. They can encode cost-cutting priorities rather than medical best practices. In fact, some insurers have deployed AI models that they knew internally had 90% error rates. This bill doesn't ban AI from the claims process. Insurers can still use AI for administrative functions, fraud detection, and tracking purposes. AI can flag claims for human review, identify patterns, and assist with workflow. AI can even provide recommendations such as reasons for potential denial, reasons for acceptance, or reasons more information is needed. That actually becomes easily trackable as to where the process broke down and creates useful data for oversight. What AI cannot do under this bill is automatically change the clinical coding that a provider has determined based on their medical judgment. Specifically, HB 1406 prohibits insurers from using AI to conduct audits of provider codes or to adjust such codes based on AI recommendations that would change the clinical judgment of a provider. It requires transparency through the record keeping that identifies AI tool usage, making these records available to the insurance department upon audit. And it creates accountability by making violations of unfair insurance practices, allowing the commissioner to impose fines or other restitution for delays or denials of care. This approach builds on what's already happening happening nationally. I think I need a nap after lunch. California led the way with SB 1120, and 19 other states are now considering similar legislation. In 2025 alone, Arizona, Maryland, Nebraska, and Texas all enacted laws addressing AI-driven insurance decisions. AI can review claims and flag potential issues for human review. It can gather and present relevant clinical guidelines, policy language, or comparative coding data. AI can provide recommendations about whether a claim appears consistent with coverage policies, and it can track and report on denial patterns, acceptance rates, and reasons for decisions, creating transparency and accountability. But AI cannot be the decision maker that changes what a physician has coded based on their clinical assessment. If an insurer believes a code should be different, a qualified human must review the medical record, understand the clinical context, and make that determination. This is the difference between AI as a helpful administrative tool versus AI as an autonomous decision maker overriding medical professionals. We want the former, and this bill prevents the latter. Our physicians are already struggling with administrative burdens. When they make a clinical determination and code a visit accordingly, they shouldn't have to worry about a black box algorithm automatically changing their work. Our patients deserve better than less than 1% appeal rates on denied claims, not because the denials are correct, but because the system is too opaque and burdensome to challenge. And our insurance commissioner needs the tools to oversee this emerging practice. Right now, insurers can deploy these systems with virtually no transparency or accountability to state regulators. The record-keeping and audit provisions in this bill give the department visibility into how AI is being used. HB 1406 is about preserving what should be a bedrock principle in healthcare. Clinical decisions should be made by clinicians, not computers. It protects the clinical judgment of healthcare providers from being automatically overridden by algorithms, and it allows AI to serve as a useful administrative and analytical tool while ensuring that medical coding decisions remain where they belong, with the medical professionals who examine and treat patients. This isn't anti-technology, it's pro-patient, pro-provider, and pro-accountability. I'm happy to answer any questions.
Representative McAleer.
Thank you, Mr. Chairman. I've got a hypothetical question. So a physician makes a determination of the problem and the solution, and then they use AI just to fact check themselves. And in the AI readout, it suggests something that he didn't think of. I'm believing that it would be possible for him to change his diagnosis and opinion based on what he learned there. Would that be correct?
That's correct. And in this case, that's a clinician using an AI as a tool. It's not an insurer who is not the clinician, who has not had hands on this patient making that determination.
Thank you.
Gee, I just read an editorial in Union Leader today about a student in Oyster River who was complaining about how she was being accused of using AI, but that it was really the teachers who were using AI to find that she was, accusing her of AI.
Yeah.
So the question is, if it's good for the goose, it's good for the gander. In other
Right.
words, if we don't think the insurance company should be using AI, then maybe the doctor shouldn't be using AI also?
Well, so that's a little bit different. That's like saying my neighbor down the street cannot tell me when my mail comes versus I can say when my mail comes. So a clinician, the nuance with a clinician is they know all the comorbidities. So when they're putting, this information in AI and saying, I've seen this patient for 10 years, they've been complaining of XYZ, I've seen these symptoms, that is very different than an insurance company getting this, we need to do surgery, we need to do this kind of surgery, and it's saying, oh, well, this is how we can deny it. Unfortunately, that's how it's being used. It's not being used as a tool to say, how can we supplement, health insurance, or how can we, make this patient's life better? It's become a money priority in that situation. So that's the problem there. It's very
Okay,
different.
So here's my theory,
Mhm.
which is different than yours.
Sure.
My theory is that an insurance company uses AI to preliminary check to make sure all the boxes are checked, all the information makes sense, and therefore they can easily approve it and send it along the way. and therefore cut down the time of wasted on having review. The question is that in your testimony, you go on and on and on about this legislation doesn't do this or does that, but I don't see any of those exemptions in here. I don't see any. All I see is artificial intelligence, which is undefined, are prohibited from using artificial intelligence carriers. Period.
On line 4,
I've seen line
I'll
5
point-
or saying it's that they're prohibited to using intelligence. So the question I have is that all those things that you say, no, these are things that artificial intelligence can be helpful and it's okay. I don't see those exemptions in this language.
the only thing it's actually prohibiting is on 4 and 5. It does talk about that that they use those other things. This is not prohibiting that kind of stuff. This is only prohibiting them providing changing the provider codes. So, and this is something that they have to maintain records on. We understand that they're using it for a lot of different, like, housekeeping type things. This bill is not on that.
So when you say provider codes, that's a number they're put in what they're creating. So I would venture is there is no software now that is actually changing what the doctor is putting in as a provider code.
So there have been many court cases across the United States right
That
now
a computer is changing the
that
code.
that the
So
insurance companies are
therefore,
using
that would
AI
that would be
algorithms.
not what the doctor had written down and sent in. That the computer is changing it.
So that it
And do we
is.
know this is happening in New Hampshire?
So, first of all, if you would like me to answer the first question. So this is happening. So what's happening is that the algorithm is set up to say, how can we deny these claims? We understand that insurance companies for years, we've seen complaints for years and years and years that insurance companies, pick denials over the people. And in this particular case, they are using the AI to look at, well, this code is wrong. I've known many personal examples where they have come up with something and said, well, that code can't be that because, it's missing this, this, this. And when you look at the chart, that this is actually all in there. So it's finding ways to get around it to deny the claims, which they're saying is efficient. It's hard for a human to actually go and check all of these things too, because the denial rate right now, or the time it takes for the algorithm to look at it, is 1.2 seconds.
Right.
Yeah, humans can't keep up with that. So, but when a doctor says, the patient, I know my patient, they need this type of coverage, we have a struggle in this country where insurance companies are outlasting their patients, through appeals and stuff. We should not have a situation in this state where
In all due respect,
we have to go to the
you have
courts.
clearly made it clear that you think the insurance companies are practicing a criminal act.
Not all of them,
I
no.
call that. You are saying is a criminal act. So let me
No.
just get this straight. The issue is not that when the computer, the AI sees something is wrong, it doesn't spit it out and a human being then looks at it. You're saying it goes ahead, changes it, then rejects it. That is criminal. That is absolutely criminal that they change the file. I can guarantee you that no insurance company is permitted to change a file.
The code
In
would-
any way, whether the computer does it or a human does it, they can't change what the claim is. And you are claiming that the computer is doing that.
They're not changing the claim. They're changing it where a doctor says they need this to say, no, they don't need this. So, whether they're finding, loopholes and stuff that are really not there because it's not actually, doing the
Okay.
patient. And maybe one day, and I don't appreciate the assigning any kind of motive on this. It's inappropriate.
Well, you just signed
But
it.
there
Motive.
are-
You just said that they're doing this intentionally.
Insurance companies have been moving more and more to profit-based practices. I will say that there are certain companies that do use AI only for speeding up their prior authorization. They use it for, flagging if there's a certain number of codes that are coming in that are appropriate. They actually will not use it for denials because they think it's unethical. So no, not all insurance companies, they're not all the same. I would never say all of us are the same. So that's not fair. But I am saying that we have a tool here in AI that can not only be an amazing tool, it can be a weapon. I can go into my AI and tell it, that I'm an amazing person. I've done all these things, and it's going to keep spitting that out. It's never going to critique me. AI right now, you can shape it to what you want. If I want to save my investors money, and part of that is telling AI, figure us out how we can deny more claims so we don't have to pay these out, then that can happen. Yes. All I'm saying is that we need a way for our commissioner to be able to look into this, because yes, the uptick in lawsuits across this state, and there's even class actions going, are not across the state, across the United States, are going up. And there are people in this state that have had their claims denied that have been covered for a long time. I just met somebody that has MS, and her, all of a sudden, she's been going to one place, and it's been denied her infusions just rapidly, and it was a very strange thing. Now, those types of cases are getting turned over. 90% rate in those turnovers in courts, but our constituents shouldn't have to go to court to get their medical care covered appropriately.
Have there been court cases here in New Hampshire?
I have not seen them yet, no.
Okay.
This is to prevent that.
Okay. Any questions from committee members? Seeing none, thank you very much. You'll have your chance. You put in a pink card, right? Okay, then you'll have your chance. Representative Pearson.
Thank you, Mr. Chairman and members of the committee. I'm Representative Mark Pearson. I'm in my 6th year as chairman of DHHS Oversight, and I hold a Milbank Fellowship in Public Health. For 30 years, I've been part-time CEO of a medical facility in Kingston with 3, soon to be 4, primary care providers. My chief medical officer said, AI is not a perfect technology and cannot be a substitute for a clinician's judgment. While helpful in providing a menu of choices, when it claims to be exclusionary, it can result in fatal delays or decision-making. And here's what I'll add, watching my staff at work. One of my PCPs sent in partial information on a patient. AI should have said, sorry, doctor, not enough information to give you a conclusion. Instead, it rendered a diagnosis, which would have been very harmful to that patient. So, to our staff, AI is a helpful tool, but it cannot be a lord over us. We welcome what it gives us. We have been using it, but we do not want it to make the overriding decision. And I believe that's what this bill is about. Thank you, Mr. Chairman.
Fair enough. Any questions from the members? Yeah, Representative Spear.
Thank you. I just looked up how AI is being used in healthcare to change codes. And one of the things I found was that in some cases, especially with radiology and things like that, there aren't even any people involved at all. They're doing all the analysis. And that there are some AI programs, there's a couple of them that they list, that indicate that that is what their main job is, is to change the codes for that the doctors put in. Do you know the name of any of those, I guess, AI systems that are doing this kind of thing?
We're a family practice office, so I would have to defer to others in terms of what the specialties are about. My concern is the conclusion. We send in information based on our clinical assessment of the patient who is right before us. Sometimes patients we know for years. And sometimes right now we have to battle with insurance companies. Believe me, I don't want unnecessary expense. But when it is necessary and we're turned down, and we usually get our way on our 3rd try, I wouldn't want a machine to do that. It's bad enough when people do it.
Thank you very much for your
Thank you, sir.
Chair will call on Sharon Bose. Bose? Bossy. You have to, yeah, there you go.
Hello, my name is Sharon Bossy, and you're Representative Hunt,
Yes, I am.
and I'd like to address this whole thing to you.
Technically, that's what you're supposed to be doing, yes.
Oh, well, good. First off, AI. This July, I went to the doctors because I found a very large lump over here, right beside my hip, and I'm going to stand up to show you how big I am. I am 4'9". Okay, the lump I had at that time was about 5 centimeters by 7 and a couple centimeters deep. That was in July. United Healthcare denied me. I've never been denied for a surgery before. Okay, yeah, excuse my little shakiness. I have a couple things happening besides the lump. But they completely denied it. My doctor wanted to take it out because she wasn't sure if it was a fatty lump or it was cancerous, and she didn't want to poke the bear. So she wanted to take it out. Well, AI saw the fatty lump. They went over it because what AI does is it scans. They see one word, they saw fatty. Bingo, it was a fatty lump. Well, I had to switch insurance companies. And my birthday being November, I turned 65. I was able to get out of the Medicare Advantage plan. That's another subject one day we'll talk about. And I'll be glad to speak with you again.
We talked about that last year, yes.
Oh, well, now that the plans has left New Hampshire, we should probably speak again. Anyway, so we'll talk about this. It was November when I got the surgery. By then, it had grown to 11 centimeters by 7, and it was 4.5 centimeters deep. I could barely walk. Thankfully, it wasn't cancer. But that's what happens when insurance denies you. And that's what happens with AI. So when she talks about AI, you can stop smiling because, the doctor uses AI because it helps. Maybe he or she's got a different idea for a diagnosis. When the insurance uses AI, they're looking for words so they can get out of paying. There's a difference. And that's enough. That is all I have to say for now.
Fair enough.
Yeah. You should think about that before you sit there and smile when somebody's talking about their life.
Well, when you talk to me directly, I would assure you that I'm listening to you.
Okay, good.
And I'm sorry that you feel like I'm smiling.
You were.
Okay.
You were smiling.
I try to be positive.
But yeah, there's smiling and being positive, and then there's sarcasm.
Okay. Duly noted. Adam Thompson.
Honorable Chairman, honorable representatives, I appreciate this opportunity. My name is Adam Thompson. I am a resident of Scenic and Historic Ward 3 in Nashua, and I'm a disabled veteran. And I appreciate the opportunity to testify here in support of HB 1406. Artificial intelligence is becoming increasingly common in all of healthcare administration. It can streamline processes, identify inefficiencies, and support data-driven improvements. And that's great. It helps. It's going to help bring costs down. But it's not innovation that's the concern. The concern arises when automated systems created by AI are used in a way to override or alter a licensed clinician's professional judgment. That's my concern. Clinical decisions are not mathematical. They're based on training, ethics, experience, and a detailed understanding of the individual patient's history and the context of the patient and his reasons for or her reasons for being seen. HB 1406 draws an important and reasonable boundary. AI may assist administrative process, but it should not be substitute for individualized medical judgments. For many people with disabilities, like myself, chronic illnesses, or other rare profiles, care is going to be rarely simple or standardized. Treatment plans may involve multiple diagnoses, overlapping medications, adaptive communication strategies, and other nonlinear progress. People with complex or atypical medical profiles are often the first to experience friction in these kinds of rigid systems. That makes transparency and human oversight very important. When insurance determinants appear automated or opaque, the trust will erode. Appeals processes can be confusing and time-consuming and inaccessible, particularly for individuals already navigating challenging medical decisions and their own complex experiences through their healthcare journey. Ensuring that clinical judgment remains central to care decisions protects not only patients, but also the integrity of the whole system. 1406 does not prohibit innovation. It does not prevent insurers from using technology to process claims efficiently. Instead, it reinforces accountability and ensures that technology supports care rather than replaces professional medical expertise. As artificial intelligence continues to evolve, thoughtful guardrails are definitely going to be necessary to maintain patient dignity, clinical integrity, and the public's trust. At its core, this bill is about preserving something fundamental. When a doctor says a patient needs care, that judgment should mean something. It should not be reduced to a data point in an automated system. This bill will only stop carriers from using artificial intelligence to change, alter, or amend the clinical judgment of a provider, right? It will only stop them from changing, altering, or amending the clinical judgment of a provider. And it leaves that decision with your doctor, your family's doctor, with my doctor, and with all the other disabled veterans doctors that I work with and see regularly down in Manchester. For these reasons, I respectfully urge the committee to recommend 1406 as auto passed.
Great. Thank you very much for your testimony.
Chairman Hunt, thank you so much.
Chair will call on Andrew Horn. Yep. Oh, no, you got to turn the button on.
All right, there we go. Members of the committee, thank you for hearing me today. I'm a software engineer who built digital infrastructure for a Fortune 50 health insurance company, Centene. I also happen to be in the top 0.4% of users worldwide of the AI platform T3 Chat, which is mostly for software developers. I've worked with essentially every major AI coding tool available, from GPT-5 to Claude to Specialize to all kinds of AI systems. I understand exactly how these technologies work under the hood, and I need to tell you, they are not what the sales teams claim. Here's the technical reality. These AI systems are sophisticated random number generators. They don't understand medicine. They don't reason. They predict what words should come next based on statistical probability, essentially rolling dice weighted by internet text. It's like having a very eloquent magic 8-ball making decisions about your chemotherapy coverage. When HB 1406 prohibits insurance companies from using AI to override doctor decisions or audit medical codes, it isn't anti-innovation, it's disaster prevention. Consider what happens today without this protection. An algorithm denies your child's necessary treatment. You ask why. Your doctor asks why. The insurance company can't tell you because the system is a black box. Even the programmers don't fully understand why it said no. Patients suffer while doctors waste hours fighting statistical ghosts instead of practicing medicine. And insurance companies, They don't save money. They get buried in lawsuits trying to defend decisions that nobody can explain to a jury. I know New Hampshire Republicans believe in free markets and limited government, but a free market requires transparency. You cannot have a fair contract where one party is rolling dice behind a curtain and can't explain the outcome. There is no liberty in submitting to a verdict that has no face, no name, and no accountability. This bill is simple. Limited government at its best. It says if you deny coverage, a human being must own that decision, not an algorithm that cannot be cross-examined or audited. It merely requires insurance companies to document when they use AI so the insurance department can investigate problems. We should not let statistical probability override a decade of medical training. A physician who has held 10,000 pulses should have the final word over a chip that has never held a stethoscope. Better to prevent the expensive lawsuit than to litigate the inexplicable algorithm. Better to trust accountable human judgment than to hide behind silicon randomness. Support HB 1406. Protect patients, protect doctors, and yes, protect insurance companies from making an expensive mistake that will cost them millions in litigation while doing harm to the people of New Hampshire. That's the end of my prepared remarks, but I would like to make a couple of points in response to some of the things I've heard earlier in this hearing, if that's okay. Thank you. So I think one of the things that people have been saying, and I want to really put a point on, this is a question of incentives. The health insurance company has an incentive to deny coverage, especially the people who work for the insurance company within. You know, they just want to save their bottom line. They just want to have their metrics look good, and that is going to incentivize them to deny coverage. You have a random number generator. Any kind of AI is essentially just a super random number generator, and the manager is going to have an incentive to save money under their purview, but that will probably, I think, lose money for the entire company because it's going to expose them to litigation. In addition, I want to mention that one thing that people haven't really talked about is what AI even looks like. So if anyone's taken linear algebra, this is just a series, nice. AI is basically just a series of matrices. So imagine a bunch, like just an infinite number of cubes of very long decimals. That's what it is. It's very, very hard to like go back and figure out why it did what it did. Now, I worked in Centene before AI was like really a big thing in health insurance. But I'll tell you, the rules engine that we use, this wasn't for provider codes. This was more for calculating how much we would pay for a particular service. Those rules engines were so complicated and layered on top of so many different kind of people who had come and gone from the company that it was basically, at least from my perspective, and I was only there a year, basically impossible to figure out why any particular thing happened. It was just kind of like a, people sort of had a feel for how things worked. There's this AI company that I would love you to look up called Anomaly, that basically their whole business model is trying to backwards engineer these rules engines. This is using AI to backwards engineer these non-AI systems because it's so opaque. The ones that we can theoretically look at are so opaque. The ones that are just a bunch of if-then statements that you could theoretically look at are so opaque that it takes a whole company, it makes a lot of money to figure out what is this going to do? How much money am I going to get if I put in these inputs? And I can't find it. I looked it up, but I could have sworn I heard a podcast with the CEO of that company that said that one of the insurance companies that they help to divine the money out of actually came to them to understand their own system. I totally buy that, having worked in insurance. I totally buy that some company would want to go to someone that divines things for doctors and is like, we need to have a better understanding of our own system. Now you want to take this system that I'm describing something that's not a black box. I'm describing something that you theoretically could go through all the if-then statements. It's incredibly difficult because it's incredibly huge. And you're now switching it for a bunch of floating cubes, an infinite number of cubes of infinitely long decimals that are almost impossible to backwards understand what's going on. Someday we may have some kind of technology to sort of understand what's going on, but I don't think that that's going to happen anytime soon, personally, because these systems are built to be black boxes. They're supposed to kind of copy the randomness of like how the brain works. We don't understand how brains work, and we don't understand really how AI works. There was a really good podcast that came out recently. I think it was Ross Douthat, where the CEO of Anthropic said, "We don't know if these are conscious." The CEO of Anthropic, I believe, if not the number one, maybe the number two most powerful, most rich AI company today, he says, we don't know if these are conscious. We should, when we don't even know something as insane as that, we should probably not have them overriding doctors' decisions. Questions?
Representative Spear.
Thank you. I just found lawsuits against Cigna, Aetna, United Health Group, Humana, for doing exactly what you folks are talking about. And they started telling me what the AI engine was that they were using to what do they call it? Downcoding. Do you know anything about what those are?
So this specific downcoding technology, I haven't personally looked into. I was asked to show up on this because I was like, oh, that sounds like a terrible idea. Allowing AI in a health insurance company, which I haven't mentioned, are normally among us software developers. We know AI company or healthcare companies are one of those places where the software engineering quality is not very high. The pay is not very high. You're not going to get the best software developers. And so whatever you're going to have that might be AI, it's not going to be very high quality in general. I'm not familiar with that particular program, but I'm here on just basic principle. I use, as I said, top 0.4% user in T3 chat, which is like itself a very specialized software developer AI chat. And I think this is a terrible idea to allow health insurance companies to do this in New Hampshire on principle. Yes.
Okay. Just for the record.
Sure.
Would you believe I absolutely agree that every decision should have a human eyes before it is decided.
Cool.
I only thought the AI was used as a tool to help process it faster.
Right.
But at the end of the day, any decision by an insurance company has to be made by a human.
Right. And we should legislate that.
Don't need to. It's already law. But we go get into...
Can you flesh that out?
We can get into the weeds of that. Correct. Okay. Thank you very much.
Can you flesh that out?
That's my job.
For me right here? Because I'm not coming back. I'm not a legislator.
We'll be on YouTube. If you just watch us, you can see us. But yes, no, this is not going to get solved today. We can't solve the world in a day. We can delve in and find out what exactly is going on, and we piece it together. But I can assure you, in my mind, no rejection should ever go out without a human eyes seeing it and being able to explain it.
Great. Let's legislate that.
This bill does not do that, by the way. This bill is
fine. Then make it do
this
that.
bill has got prohibitions and it's got ors and it's got all kinds of, nonsense. I don't know where it came from, but it to get where we want to get, we will have to rewrite the statute. We will have to rewrite this bill, but we will get to the point because you can see that. The only thing I would caution you on is that this whole bill assumes that somehow the insurance department's going to sniff it out. Okay, this bill, as is written, says that the insurance company is going to tell the insurance department they're using AI. Okay, then it's up to the insurance department to figure out, going through audits, to figure out that some decision was made without humans not reading it. I would say I'm not sure our insurance department can do that problem, solve that.
Chairman, have you ever worked in a health insurance company?
Have I ever worked in a health insurance company? No, I've been doing this for 40 years, and I have a little bit of insight of what goes on in the insurance company.
Chairman, are you a software engineer?
I used to sell Apple and IBM computers.
Okay, but that's a different thing. Chairman, I worked for a health insurance company, one of the Fortune 50 companies in the world, or in the country. I am a software engineer. I definitely believe that this could potentially be happening in software companies.
It potentially could be happening. There's no doubt in my mind anything is potential.
It is happening.
The question is the ability to us to stop it and fix it. That's the issue.
Yes.
Okay. You have to remember is that that just passing a law and saying you can't do something does not make it stop from happening.
It's progress, Chairman.
Again, our job will be to figure out how to write this and get to the point that you're making. If you can says deny coverage, the human being must own that decision.
Yes.
That's where we want to get to.
With legislation.
We can do that. We can make that happen.
This year.
No, we're run out of time.
Well, AI is happening very quickly. Things change very quickly. This needs to happen right now, Chairman.
I don't know which legislature you're talking about who can do that.
Yeah, so
I was good up until that point.
This committee is very successful in getting problems solved. It might not happen overnight, but we do get problems solved.
Mr. Chairman, I recommend you take a second look at this legislation and vote ought to pass.
If I were to pass this lovely piece of legislation, it would be dead before you know it, because everyone would take one read at it, and the Senate won't like it. The governor will veto it. There is no. It is not your testimony is much clearer than this bill as written is. This bill is in all due respect, I've written a lot of law, okay? And I know how law works and how we want to make it enforceable and so that it can be addressed and can be done. But just slapping something together and hope it's good and just passing it doesn't get you there.
Mr. Chairman, I do quibble with you about this not getting through the Senate. I believe Senator Birdsall, the majority leader, is one of the co-sponsors here.
Look at that. Yeah, Senator Prentice. Yeah.
So I think that this has quite a strong chance in the Senate were it to reach the Senate.
That's your opinion.
But Senator Birdsall does not know about it.
All right, we're all set. Okay.
Thank you for your attention.
Okay. Okay. Chair will call on Michelle Heaton from the New Hampshire Insurance Department.
Good afternoon. Michelle Heaton. I'm the Director of Life and Health at the New Hampshire Insurance Department. The department supports a lot of the sentiments from the sponsor here. AI is definitely something that's on everyone's radar, and we do need to take proactive steps to make sure that it's being utilized appropriately. And because we agree with that sentiment, we've been actually working to try to implement rules with respect to AI. So a couple years back, we issued a bulletin about AI use in the insurance industry. And since then, we've been incorporating those same principles into our various administrative rules. And in particular, in our utilization review rules and our claims processing rules, we have that are currently in rulemaking. They have additional provisions to address AI. And one of the key things is that no denial can be made without a human reviewing it. So I think that goes along with a lot of the sentiments and a lot of concerns we heard that, machines were making these decisions. They are not. They can be, AI can be used to assist in the process, but that final denial, if it's an approval, no problem. But if it's a denial, then a person needs to be reviewing that denial. And I think in addition to that, it's worth noting that this bill is related to managed care 420J.
Right.
It does not apply to Medicare, Medicaid, VA TRICARE, or self-funded plans. And I think there's a lot of reference to a lot of different court cases. To my knowledge, all of those court cases related to self-funded plans or plans that are outside the department's regulation. And part of that is because under our insurance laws, we do have a lot of protections in place. If a claim is denied or utilization review is denied, the carrier is required to send a notice to the provider and or the patient, or sometimes both, explaining why the service or claim or whatever they're seeking is denied. You cannot just say it's denied. They have to state the reason for the denial, whether it's they don't have enough information to make that determination, or they think based on the information that was provided to them, it's not medically necessary because of X, Y, or Z. That needs to be explained, and that's what we're trying to make more clear in the rules that are currently in rulemaking, what exactly needs to be included in those notices. And then when there is a denial, there's the appeals process and again, external review. And all of those are to counteract, erroneous or people overlooking certain information. And so taken all together, there are a lot of protections in place. And I know I was testifying about this earlier, but there is an expedited process as well. So if people need access to care immediately, there are much tighter timeframes for those determinations. And those appeals and the right to external review is also, a very short time period that those things turn around. So while we understand the concerns here and we're on the same page about the concerns, I think as written, there are just some technical defects in here that would need to be cleaned up. In particular, if we're going to be defining any terms, we would prefer that we stick to the way they've already been defined in our rules. We would hate to have legislation passed that would conflict with how we've been defining these already, because that would cause us to have to go back and do a whole lot of rulemaking. We're also working very closely with the National Association of Insurance Commissioners and other regulators to make sure that as we are delving into this new world of overseeing artificial intelligence, we're doing so in a way that makes sense across the entire country and that we're not outliers. So a lot of that AI bulletin and all of those definitions and language that we're using in our regulations is consistent amongst other states in the country. So I'm happy to answer any questions.
Okay, so can you have rewrite this paragraph so that states what the current law is that under 420J that
We're
has
happy to work with any stakeholders to clean this
and
up.
we'll need it for March 2nd.
Okay, no problem.
Thank you. Yes.
I had listed a couple, 4 companies that were being currently sued for this. And you said something about ERISA really fast. You're always talking very fast.
Sorry, I'm trying to get in that 5 minutes that I wrote down.
She's assuming that we all understand that this exemptions from 420J.
No, my question is the companies that I quoted, like Cigna and Healthcare, United Healthcare, and those guys, were they all ERISA plans? Do you think?
All of the court cases I've seen, and there could be ones out there I'm not aware of, but the ones I saw were where those carriers are acting as the third-party administrator for a self-funded plan.
I see.
And so the requirements for those types of plans fall under ERISA and are very different than the health insurance laws that we have on the books in our state.
So yeah, I didn't. Did United Healthcare do ERISA? I didn't know that United did, but Cigna certainly is.
There may be some with respect to the Medicare Advantage market as well, and again,
that's a whole
outside our
nother thing. In
jurisdiction.
Medicare Advantage, Medicare, you hit 65, you're exempt. You're out of 420J. Right? And I have to admit that's why I was smiling. But okay. Sabrina Dunlap. I always like to leave Paula last. Old habits.
Good afternoon, Chairman Hunt and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem. I'll try to be brief, but we are opposed to HB 1406 for a number of reasons. To start with, from a carrier perspective, Speaking for Anthem, and I think for all carriers, as was noted, we do not use AI to deny claims or down code. Decisions involving clinical judgment are signed off by a human. So Anthem might use AI for automation or to speed up approvals. Denials are always reviewed and determined by real people with clinical training. I want to be very clear about that. So we do also use AI to help catch patterns of fraud and abusive billing practices. Fraud, waste, and abuse costs the healthcare system billions of dollars every year. And the language in this bill is so broad, it could definitely interfere with current uses of technology that are widely accepted and helpful. I would also just note, I think it was already noted, that the insurance department issued a bulletin on AI in 2024, and they're working on rules, and clearly the department has the tools needed to enforce regulations in this area. And I don't want to point fingers, but I think there's been plenty of disparaging comments made about health insurance companies during this hearing. So I would just note that providers use technology companies and EHR companies and billing companies that help maximize revenue and other such things using AI. So I just want to be fair in that it's not just insurance companies that use AI. So anyway, we think this bill is very problematic as written and unnecessary, and hope you will vote it inexpedient to legislate. Happy to take any questions. Thank you.
So there was a bulletin actually done. Did the bulletin make it clear that a human had to approve a denial? Yeah, so that would be great to get a copy of that bulletin and then just send it to Representative Craig. Well, yeah. Yes.
He gets it.
Yeah, right. Okay. Any questions for Ms. Dunlap? Seeing none, thank you very much.
Thank you.
Okay, Paula, you get to wrap it up.
Thank you, Chairman Hunt, members of the committee. For the record, my name is Paula Rogers, and I'm here on behalf of AHIP, America's Health Insurance Plans. The testimony was interesting, and when I first picked up the bill, I was sort of confused. Of course, what I zeroed in on was in the the analysis is using artificial intelligence to change clinical judgment, which sort of shrieks at you. It's unacceptable. And so I thought, well, in what venue is the bill placed? And I immediately thought it was probably an appeal of some kind where people are looking for peer-to-peer equality when looking at an appeal. And then I thought, well, what the heck is an AI element to that? So when I turned it over, what I realized, it's really about claims processing. And when the chairman said something about, is the AI program going to change the clinical judgment of a provider who filed a claim? My immediate reaction was, well, I certainly hope not. And so what I understand, and of course I'm not internal to a company at the moment, but let's face it, you've got people, beyond the fact that you've got providers, payers, and an AI system, you have human beings in a system, and things go awry, and one hears things here and there that may not actually apply. When I heard some of the earlier testimony, I heard about the word downcoding came in. And there is also the obverse of that, which is upcoding. And so Sabrina Dunlap brought that up. So if you go online, you will find coding companies that will train providers to do the very best they can to get what they should get out of their claims. And then, of course, there's the pressure, some on the other side, to make sure that the claims that are coming in are properly coded as to complexity and to the reimbursement level. And so that's a natural tension, and you, as policyholders and regulators, policymakers and regulators, as regulators, need to make sure things are going properly. So when I looked at the bill, I sort of picked it apart, and I think the chairman's suggestion to Michelle Heaton to take a look at the bill and draft something that captures what we all agreed to, is that an algorithm, an AI program, if there's going to be a denial, that somewhere in that mix is a clinically appropriate person that knows that that's going to be denied. And so That's what I hope the committee will take into consideration. And it looks like there's a lot of pressure on you to do something fast. So I'd be
Yesterday, yesterday. But if we can get it solved this election cycle, this biennium, that'll be great. Okay, I have no more cards. Does anyone else like to speak on 1406? Seeing none, we'll close the public hearing on 1406 and ready to start 1554. So I'm officially writing ought to pass as amended for that bill. Good afternoon, Representative Miles.
Good afternoon, Mr. Chairman, and thank you, members of the committee. For the record, my name is Julie Miles, representative. I represent Hillsborough County District 12, the town of Merrimack, and I'm here to introduce an improvement to our current peer-to-peer process. House Bill 1554 strengthens the clinical integrity of prior authorization by ensuring when medical necessity is questioned, a treating clinician can speak directly with a qualified clinical peer at your insurance company. This bill is about making sure your doctor can speak for you. Current law references peer-to-peer review, but significant gaps remain. Access may be cut off based on timing. The reviewing individual may not be of the same practice specialty, and providers are often not told who specifically at the insurance plan is reviewing their plan of care. These gaps create delay, often frustration, and unnecessary denials. House Bill 1554 guarantees peer-to-peer access, means your doctor speaks to the health plan's doctor at any point, at any stage of the prior authorization, including after the appeal is started. As it stands, your doctor can only talk to their doctor between the time you get the first denial and the time the appeal starts. Once the appeal starts, you've lost that opportunity. Your doctor has lost the opportunity to be your voice for your care. So that's why this bill is significant. This bill also requires the reviewer to be actively licensed, practicing in the same or similar specialty, and qualified to assess the service under review. It requires disclosure of the reviewer's name, the doctor's name. It includes the licensure they have, the issuing state, and their NPI number. The bill does not change any prior authorization. It does not mandate any approvals, and it does not duplicate an appeals process. Appeals are administrative. A peer-to-peer review, doctor-to-doctor discussion, is clinical and consultative. Early clinical dialogue often prevents prolonged appeals and reduced system-wide costs. House Bill 1554 is not redundant to current law, and it does not conflict or undo any prior authorizations reforms passed in SB 561 in 2024. Instead, it complements it, and it complements that work by addressing who conducts the review, when it must be available, and how transparency is ensured. Some opponents will argue that peer-to-peer review already exists in statute as a result of legislation passed in 2024. That assertion is technically partial, but substantively false. SB 561 was an important step forward. It requires carriers to offer peer-to-peer review and establishes timelines around the process. However, that statute contains a significant gap that this bill does address. So under current law, access to peer-to-peer review can be cut off based on procedural timing, particularly once the appeal has been initiated. The reviewing individual does not need to practice in the same or similar specialty. They don't need to be actively practicing, and the treating provider is not entitled to know who is reviewing their patient's care or even obtain their NPI number, which is very widely public information that should be provided to your doctor. We are in the prior authorization process in the first place because the treating physician, the clinician that knows the patient best, has already deemed that this care is medically necessary. So when that judgment is overridden, patients do deserve a timely, meaningful clinical conversation without any delays or administrative barriers. By clarifying qualifications in timeliness and enforceability, House Bill 1554 protects patients, it respects clinicians, and it promotes faster, more appropriate care decisions. I respectfully ask for your committee's support when it matters most, and so your doctor can speak for you. One other point I'd like to make, we did hear from Michelle Heaton from the DOI earlier. She did state that there are only about 50 to 100 external reviews a year being utilized across a state of 1.2 million people. So that means that that process is not being utilized. Patients are not getting that far in the process. Maybe it's because they're too sick. And that's why specifically your doctor should be able to speak to the doctor at the plan to be your voice. Thank you.
Questioned out. Okay, Michelle Heaton from the New Hampshire Insurance Department.
Good afternoon, Michelle Heaton from the New Hampshire Insurance Department. I'm the Director of Life and Health. We've heard a lot about peer review or prior authorization today, and I think just this whole session. But I want to remind you of a couple things. Just a couple years ago, the legislature passed SB 561 with respect to prior authorization, and that became effective January 1, 2025. We are still in the process of implementing that law. And that's why we have those INS 2000 rules that are imminently going to be in rulemaking that are going to expand upon what that bill put into place. And one big component of that bill was expanding peer-to-peer review. So as part of that bill, we opened up peer-to-peer review more by allowing providers to request that peer-to-peer at any time, either before or after the denial. So previously, it wasn't until you had that initial denial could you request peer-to-peer. Now it's opened up, so you don't have to wait for that denial. If you're putting in a prior authorization or something like that that you're going to need approved, you can request that peer-to-peer right away. And so that is one of the new improvements. It's still fairly new, but that was effective starting January 1, 2025. The only concern we have with opening that up a little bit more is that when we're talking about the process for, prior authorization or claims, you have the initial request, there's a decision made, then there's the opportunity to appeal, and then you're going to external review. Obviously, it's up to policymakers to decide what that policy is going to be. But the only concern we have is that, we could start going down this road where we're getting to external review or we're internal review. And now the provider goes back and does the peer-to-peer. It would be much more efficient if those peer-to-peer reviews were happening initially and not waiting till later in the process. It's going to, it's just inefficient. It's going to cause all of these other things to happen. So we would like to encourage providers, if you want that peer-to-peer, you should be doing it, sooner rather than later. So I see that there could be some, administrative inefficiencies if we allow peer-to-peer at any point, and there's less urgency on the provider to request that peer review earlier on, which is really, I think, what we all want is, the patient, if they need this care, to make sure they have access to it sooner rather than later. And I think that's most of it. I think there was some other stuff mentioned in testimony, but we do have rules, the 2000s that are imminently in rulemaking. They are posted on our website. They'll elaborate on the peer-to-peer process and prior authorization process as well. So I'm happy to answer any questions.
So, if we have a denial, should we be putting into the statute a peer-to-peer process right away? I mean, somehow, like you say, in a perfect world, it would be nice that they happened before the denial even occurred.
Yeah, and that's what the new law did, is it allowed them to request peer-to-peer at any time. I think what
Did
this,
that law go into effect? Is it?
Yes,
So
as of-
how many people have been taking advantage of that?
I would have to check with the carriers on that. That's something that they track. We do have coming in April, we will be posting our initial data collection numbers on prior authorization, but I don't know that they get as granular as when did people request peer-to-peer and how many are actually requesting the peer-to-peer. But that's something we could definitely look into in the future.
Right. Well, the question is whether this bill, we want to expedite this bill so that peer-to-peer is occurring. And it still has the same requirement that the person has to have the credentials of the peer, having to make that peer.
Yes, under
they really are peers.
Yes, under our rules, it definitely goes into a lot more detail about that. You can't have someone in a non-like specialty reviewing something, so you don't want a podiatrist
exactly.
reviewing,
Right.
OBGYN care.
Right.
But I mean, under their current law, you already have access to peer-to-peer. So I think this would only expand it, past those initial, and I think that's where you get a little bit
We don't want it to drag
inefficient.
too long. We want the peer-to-peer to happen sooner.
Yeah,
rather
and
than
that is under current
later.
law.
Because for all intents and purposes, the external the review is going to be a peer-to-peer, but now it's a peer-to-peer with someone who's outside of the insurance. So it's expensive and time delay.
Yeah, which the peer-to-peer is a little bit different than, someone reviewing it. So the peer-to-peer is where they actually get on the phone and have a discussion about it.
conversation,
Yeah.
right.
As opposed to just, filling out a form, submitting it with some
Right.
documentation. So it does allow for, getting into a little bit more detail about, why this is
Yeah.
different for this patient.
And how this example, and they can talk about their case experiences and say, in terms of, what in their past cases. No, I understand it's a
Yeah.
conversation. Right. So the question is how do we make sure that happens quickly? But you're saying it's already on the statute.
Yeah, that was one of the new provisions in the SB 561. So
Right. And what RSA is that here?
it's in 420J6.
20J6.
And I would,
Okay.
I'm not going to guess on the Roman numerals, but it's towards the bottom.
Here. So, right. You want to ask a question?
If you believe that SB 561 indeed was an important step forward, but it still requires carriers. There's still limitations on when your doctor can talk to their doctor. So it is not just anytime they want. There's a very specific timeline. And if the physician is unable to get the doctor at the plan on the phone or vice versa, the patient loses out on that opportunity for your treating physician to talk to the plan's doctor.
So was there any timeline or anything about when the peer-to-peer conversation occurs? Because they're both very busy people.
There are requirements that when it's requested, the carrier needs to take steps to make sure someone's available within that time period. I think the other side of it is something that's a little outside of our ability.
Right.
If the provider is busy and unavailable, that's not something that we can necessarily regulate. But that's why even if there is an adverse decision, they still can request peer-to-peer after that. But those rules are going into rulemaking. If there's adjustments we need to make that more accessible, we're happy to talk about that.
That's a good one. You got to think of how do you take two busy doctors and get it and give them, how do we set them up so they talk to each other?
The issue is really about getting the denial and then someone wanting to do the right thing. So initiates an appeal. And once the appeal is initiated, you lose the opportunity. That's the issue here. Like, your doctor should be able to speak to their doctor throughout the appeal process until the final denial. Period.
Is that what happens now, or?
So when the initial, say it's a prior auth, so the initial prior auth goes in, they can request peer-to-peer at any time. Once
Starting
the
now,
denial,
even before the denial has been made, you can request a peer-to-peer conversation.
yeah, and then
Well, they wouldn't be requesting a denial until they know that they wouldn't be requesting a
They're just
conversation.
going to assume it's going to not be denied.
And that would be a lot of administrative
so
burden.
so what she's
So,
saying
yeah.
is that's nice. Thank you very much, but no.
So
the
even
busy doctor is not going to bother making that phone call until the denial has occurred.
yeah, so once the denial occurs, you can still request peer-to-peer.
Right.
But there is also the appeals process.
Okay.
And so
but
there's
what we're
different
asking is
timelines.
in that period of time before the appeal.
They can still request peer-to-peer.
So how do we make sure that that conversation occurs? Right? How does
This is simple. It's very simple. Just allow the physicians to talk to each other at any time during the process until the final denial. That's it.
so there is no time limit or time, you could just saying let them, so that's where,
Well, I think
that word put in that language where we all, you probably freaked when you said at any time.
Yeah, and I think
that, and that, we've never done that before on any legislation to say, pick up the phone anytime you want.
yeah, I think there's more just administrative hurdles because when you do that initial determination, one person's looking at. Once you appeal, it's required that someone different look at it. So it's not that it's the same person doing all this. That could be, 3 or 4 different doctors, depending on how many levels of appeal and external review and all that are doing it. So then it's just kind of an added layer of like, well, which doctor, when you're requesting the peer-to-peer, are you talking with? And just the logistics of that. But
Right.
it's not
keep saying
insurmountable.
You want after the denial, and then, but before the appeal, you want at any time in that period, you want
After the
peer-to-peer.
appeal is initiated, they lose the opportunity to speak to your doctor. Your
Got
doctor
it.
loses
No,
the
I got it.
opportunity.
I got that.
Yes.
So I'm telling you, the window of time you're
Mhm.
looking at is after the denial has occurred,
Mhm.
before the appeal is filed.
And the appeal could be filed moments after the denial is received.
Who
It's automatic. It's office politics.
Oh, okay. So that's the next question
Yes.
is
A good citizen,
who files the appeal?
the office administrator could say, "Oh, I got the denial," and then click the buttons, and the appeal
No,
is
so
initiated.
therefore, what we want to do is
It's not that
statutorily say,
complicated.
don't do it. Don't appeal right away.
Why not let them talk during the appeal?
That's what I'm saying. They should be able to talk during the entire appeal process, not just between the denial and the initiation of the appeal. Because if the appeal is initiated moments after the denial is received, the opportunity is lost.
So
it's gone.
You want it during the appeal process. You want the person to still be able to talk peer to peer.
Yes, because the appeal process could be initiated moments after the denial.
You don't have to repeat
Correct.
things to me.
You're
I
correct.
get
Yes,
it.
correct. Yes.
Okay. That because the appeal could have been too fast. Okay. That we can't expect that window of time to be where the peer to peer occurs. This is where you're saying that you want that appeal before the appeal decision is made.
Anytime before the final
Before the so now what is the sequence of events?
So you
now?
have you can request peer-to-peer, you get your denial. You can still request peer-to-peer. You can appeal it. Once you appeal it, there's another decision. If that's still a denial, depending on the carrier, there could be a second level of appeal. If there's not, you can also go to external review. So at any point in those time, I think what this legislation is intending to do is open it up. So at any point in that time, you can request peer-to-peer. What I'm not clear about, and I'd have to look at it a little bit more, I don't know that there's any limitation on that. So you could still request peer-to-peer at each
Okay.
one of those levels.
So your
and-
assumption is that once the appeal is made, they can't have a peer-to-peer. And you're saying you're not sure whether they could still have a peer-to-peer in
I don't
that
think there's
window?
anything preventing them from allowing peer-to-peer. I don't know if it's being done, but it's not necessarily required.
So in other words, if we fix the statute
Mhm.
to make sure it says that peer-to-peer can occur at any time,
Mhm.
which is, I think, what this bill says, right?
Yeah, I think that's what it's
It
looking
says,
to
peer-
do.
right to peer-to-peer review regardless of whether an appeal has been requested on behalf of the claimant. So
Yeah.
the question is that there's no harm in that?
The only concern we had is that it could lead to inefficiencies if there's, instead of requesting the peer-to-peer right away, you're waiting till the end to do it. But other than that,
Inefficiencies.
it's up for you guys to determine.
Well, the question is, the claimant retains the right to peer-to-peer regardless. The question is, how many peer-to-peer conversations do we allow? If you only allow one, then how much time does it really delay?
Carriers are here, they can talk
Yeah.
more about the peer-to-peer, but I just
Okay.
know that we've required peer-to-peer from when the request is
today is
made
a unique
until at
day.
least the
Thank
denial.
you very much, Michelle. And yes, okay. All right, Sabrina. Now, of course, you're going to have to say you need to go back and talk to the bosses.
not a medical
the
director, so-
bosses and are doing it. So, what is the harm in this language that says a peer-to-peer can, regardless of whether an appeal has been required, simply because there is this knee-jerking reaction to appeal too fast, and that the way the statute is written, it appears that you can't do a peer-to-peer after the appeal has been requested.
Well, so just for the record, I'm Sabrina Dunlap, Director of Government Relations for Anthem Blue Cross Blue Shield. So I guess my take on the bill is just that I would emphasize that what happened a couple years ago was a significant bill. I don't want that to be downplayed. I mean, there were a lot of stakeholders. Concessions were definitely made by carriers, and providers would probably say by them too. There was a lot of compromise. And when I took this proposed bill, which we respectfully oppose, to folks who deal with peer-to-peer and are in this space, I'd say they were pretty confused as to what exactly it was trying to do in light of our existing, I would say, robust prior auth.
Right.
Sorry, I was just distracted by the chatting behind me. In light of what already exists. And so it's not totally clear to us what this new language is trying to do. The existing statutory language allows peer-to-peer to be requested before determination or after a denial, and it has to be made available within 2 business days. That's an existing statute. Under New Hampshire law, carriers have to have medical directors who are licensed in New Hampshire who have responsibility for all utilization management in the state. It goes into more detail about the options to request peer-to-peer. And so I think, relative to other sort of prior auth statutes, we have a very good and robust peer-to-peer process. So I honestly am not quite clear on what the bill is trying to do, except, I guess, make peer-to-peer available at any point in time. And I just think from an operational perspective, that gets complicated because there are requirements around appeals and the process we have to follow. There's processes around external review, which the insurance department gets involved in. And so I just think it does become complicated. It might sound simple, but I think it gets very complicated trying to operationalize peer-to-peer review at any point in time. And I do think what we have already is quite extensive.
Right, but what we're hearing from the testimony is that there is a bug in the problem, is that the secretary who's working in the doctor's office, when gets the email that the request has been denied, just unilaterally goes and files for a review. And the concern is the language is not clear, that just because they went and requested that so quickly does not bar the opportunity for peer-to-peer to occur. And certainly that obviously we would hope that the peer-to-peer would occur long before a final decision's made, but that we should hope that it retains the right to have at least A, which I see the word letter A, not multiple A peer-to-peer in that time frame. So now that I've been thinking about it, it really doesn't really matter when that peer-to-peer occurs, as long as it's done before the final decision is made. So anyways, we're going to have a subcommittee on this
Okay.
on the 2nd.
Yeah.
Okay.
Okay.
So I would say is now that you understand, and you can always play this tape again to see to make sure you understand what the problem is. And I hear you what you're saying. There was a lot of work and a lot of negotiation, but probably it never crossed anybody's mind that appeal could happen even before anybody had a chance to absorb the denial.
Yes, I think.
other words,
Thank you.
that-
I think I'm understanding the issue, and I would just reiterate
So
that.
either we give a time frame for the claimant, the request for an appeal, that the appeal must occur a week later or sometime later or sometime before, but that appeal, and that yes, it is true that the peer-to-peer could happen any time, but we would certainly hope that that after a denial has occurred, that regardless of whether an appeal is filed or not, that peer-to-peer has occurred.
Okay. I think I'm following.
Does that make sense, Paula? Okay.
All right. Well,
Why
thank you for the opportunity.
Okay.
We are happy to work with others and try our best to understand this.
Okay.
Thank you.
All right. So we've already had Michelle. Okay, so we're not, that's just you, Paula. You're wrap it up as you do so well sometimes.
Very quickly, it sounds like peer-to-peer in the period after there's been a denial and an appeal somewhere, there should be one. And let's think about that. Why would you like that? Well, you might settle out and just pull the appeal. So maybe it works. I don't know. The plans, we'll have to look at that from a more organized way. But that was my general sense. The other thing that came to mind was sort of moving away from a little latitude on what the peer would look like that you are going to have a review with. And so if you go to the last page of the bill, it talks about the individual should hold an active license in the same or a similar specialty as the treating provider and is actively practicing. That could be a problem, the actively practicing, because I don't know.
Where are you seeing that?
This is on the very last page of the bill. So you're looking at line 3.
Page 3? You are on page 3?
Yes, the very last page.
Isn't that already current law, or is this a new paragraph?
Oh, it's the second to the last page, obviously.
It is a new paragraph.
Over here, John.
Right, on page 3.
So
No, but it starts, the RSA, that, what you see on page 3, technically starts on line 31 on page 2. Number 4, new paragraph.
Okay, so I don't have the lined version in front of me,
Okay,
which is
so it's
causing me a
now,
problem, but it's the very last
it's
part of the-
section 4, and I know
Okay.
you know what that means. Section 4 is a new paragraph, so that means that's not in the current statute.
Correct.
And you're saying it's,
The concern is that you've got, the peer would have to be more closely aligned in practice to the doctor that is involved in the potential appeal and would have to be actively practicing. So the carrier is going to have to choose from a panel of appropriate people, and that could mean that you'd have to have a broader panel of people that are going to participate. So that was the only caution I saw in the rest of the bill. Because,
but if they're going to have a conversation,
yes,
you would hope that both physicians are are equal in terms of their knowledge and expertise and of whatever the
correct.
diagnosis is.
And you've got the tenor of it, but it used to be in the first part of the bill, a clinical peer is, in this context, shall be a healthcare professional who has demonstrable expertise to review a case, whether or not the reviewing professional is in the same or a similar specialty. So this is broadening the category of people that would qualify.
Okay, so.
which may be fine,
Well,
but
but
it's,
so that was what was already in statute.
yes.
Okay.
What I
and
just
so
read.
now we're saying this peer-to-peer is different, and that's somewhat problematic if you ask me.
Well, what?
But is an intent that because the other one is what would have been happening with the third, the after the denial and then the review. Okay, so but this is saying we're actually looking for a little higher standard of that conversation, which then does kind of move the goalpost back a little bit in
Which
terms
sort
of the
of
cost to the insurance, or in terms of the panel that the insurance company has to.
Could be a strain.
Because the question is, would they be the same people?
You may need more of them. I don't know. But the other thing, and I do want to, when there's further discussion, we can discuss that further.
Right.
But you know what has occurred to me listening here and on the Senate side is that consumers do not know about the exception process for prescription drugs. They simply don't know about it, and they don't take advantage of appealing or objecting to carrier behavior. They just don't seem to. And I cannot understand why that's the case, because I think the department has strained, and I think policy committees have strained to get these procedures in place. Plans are supposed to sort of keep them in the plan documents. They have to post them on their websites. Something's amiss.
Yeah, and almost like, I'm looking at the insurance, but it's almost like we need to, when anybody's got bad news, that to what to do about that bad news should be in a little bolder print, or something bolder print. Be able to contact the insurance department if you need more explanation of what so that a bigger opportunity, because like you say, I mean, I think my wife just got a denial on a prescription drug, and I said, well, that's fine. You just use the process that they wrote in there about how to appeal it, and she it wasn't the way they write that letter.
And
it made it look like you're oh well, here's are the other ones we suggest, and rather than yes, you can pursue an appeal.
And the lack of that knowledge creates legislation, because people come in, they're upset, understandably.
Right.
And then they're here and they might be advised that they could have done this, that, or the other thing. But when they leave, I don't know who's going to reinforce it. It's just an odd situation.
Yeah. So we have to talk about how to companies do something more to know the process. Okay. Thank
Here
you,
she
Paula.
comes. Help.
So we do actually have all of that in those requirements in the plan documents and as part of the explanation of benefits.
Okay.
It's we're trying to strengthen them a little bit in the rules that we're promulgating right now.
Okay.
But part of that explanation of benefits is if you have a question, contact the insurance department.
Okay.
But again, this only applies to those fully insured plans.
For
You're
20
not
people,
going to
right.
see that in
It's not
all
gonna
of
help
these
my
other
wife
plans.
on the Medicare.
Yeah, but
Mention her age.
despite that, I think, again, if you don't read the documents, and even an
And then you get the
explanation of
pages and
benefits
pages,
can
right.
be 10, 15 pages long,
Right.
and you don't make it to the last page that talks about your rights to appeal. There's flow charts, there's, numbers to call, there's forms included for external review. All of that is included.
Is the
but
contacting the insurance department in boldface, bigger
It's
font?
required in the rule, in
bigger,
bold,
bold,
prominent
bond.
font. We can make
Okay.
it bigger if you guys like it. We are in rulemaking.
Make it
but-
even bigger. Well, maybe it needs to be on the top of the first page rather than at the bottom of,
Yeah.
of the last page. That would be my recommendation.
Okay.
If at any time you do not understand, please call us. Something like that.
We will take that into consideration.
Thank you very much. Okay. Do we have anybody else that would like to speak on House Bill 1554? Seeing none, I will close the public hearing and open up the public hearing on 1656. Do I see a rep in the room? Motion. No, look, tell us she was on this, but I assume she's gone for the day.
Who's gone for the day?
Well, the rep we had this morning, who showed up late. So we have no rep here. Does anybody want to speak towards? What's that? I'm not talking about it. I haven't been to the Olympics and I can't forget.
I'll speak on it. Does someone need to introduce it though?
Yeah, no, we don't need it. It's just, that's, our department is impartial, that's perfect.
So,
You know what the-
this is an issue that got brought up a couple years ago, and the department did some work with some advocates to address the issues. There was a perception that this pelvic floor therapy is not readily available. It's not being covered by insurance. We actually did a lot to look into this. We did some claims analysis. We reached out to carriers. We reviewed clinical guidelines, and we weren't able to find that this care was not available. We actually found the opposite, that it is available. There are in-network providers providing this kind of care, and there are claims being paid out for this care. So we had issued that report, I think, a couple years back now. I mean, the only thing I'd really point out to you is, as drafted in this bill, it does create a benefit mandate. It will require deferral under recent federal guidance. There's a very strong likelihood that we would have to defray this, and it's our understanding, based on the previous research we did, that this is being covered. So I don't know that a new mandate is necessary.
Okay, does everybody understand that how under the Affordable Care Act, any new mandate that we passed after that, what would the state has to pay for it? So, yeah, there was, I always said because I was here when the whole negotiations were going on, and I said, geez, how are they going to handle with the Affordable Care Act? How are they going to handle the fact that each state has different mandates? And I kept saying, I want to be a fly on the wall when they had that conversation. And sure enough, the end result was they basically said, okay, we're sticking a stake in the ground, and each state is right now stuck with the mandates they have. And they could repeal them, but that any new mandate, they would have to pay for it. So that pretty much stopped mandates coming in general. All right. Sabrina, you want to wrap up?
Very brief.
Right. Tell us that you're already covering it and all is good.
We're opposed to this bill. We're already covering it, and the question's been asked and answered before. So, no, but really, we are covering this, and I double checked that, and so we really don't know where this is coming from or what the need for it would be. And for the record, Sabrina Dunlap, representing Anthem. I am happy to take any questions. Thank you.
Any more comments? All right. Thank you very
you.
much. We close the public hearing, and we close our subcommittee or our hearings. This is the last. We've now heard all 54 bills.
Oh, my God.
Really? Today?
No more bills.
That is it?
We haven't heard yet. We did the early bills. And these were all the late bill, all the second round of the bills. So we now heard them all. Doesn't mean we still got, I don't know, is there a bill that you're thinking of that's still out there?
This was.
We'll be upstairs next year, tomorrow.
Next year.
Next year.
This was
250, so we were.
Okay,